The opening will be start soon. So we inform to the guests and participants that present at the venue, please do not join in Zoom meeting to prevent the noise from the sound system. Thank you.
Good morning, ladies and gentlemen.
My name is Dita Irianti Rukmana.
And I am Suryanata Kesuma.
It's a precious chance for us to be the master of ceremony and join this special occasion. The first is Borneo Health International Conference, EBHIC, on Tuesday, November 23rd, 2021 in Mercure Hotel, Samarinda.
In this beautiful moment, I would like to welcome all the participants who join us in Zoom meeting conference or live streaming on YouTube channel.
And we would like to greet our incredible speakers. It is truly an honor to have you here.
Ladies and gentlemen, as our welcome greetings, we would like to present you a traditional dance to symbolize our dedication to show hospitality and respect. As a way to introduce our land, it will perform in a Lai Bara dance from Art Club student Health Polytechnic of East Kalimantan. Please welcome in stage Lai Bara dance.
This dance tells about a traditional head of a tribe was named Lai Bara. He was a very wise leader and loved by all his people. He was able to make the lives of his people safe and peaceful without forgetting the cultural values. This makes him a leader who is respected and feared. This dance is the form of an appreciation and remembrance to the traditional figures of Kalimantan who were able to make Kalimantan becomes a fertile land and full of life for its people until now. And once again, give applause for the Laibara dance.
Okay, thank you. The Honorable Head of Health Human Resources Education Center, Ministry of Health Republic of Indonesia, Dr. Sugianto, Bachelor of Education, Master of Applied Science.
The Honorable Director of Health Polytechnic of East Kalimantan, Mr. Dr. Supriyadi, Bachelor of Nursing, Master of Nursing.
The Honorable main speaker in this virtual conference, Naohiro Hohashi, PhD, RN, PHN, LSN, HS, FAAN from Kobe University, Japan.
Dr. Afzal Mahmud from University of Adelaide, Australia.
Barakatun Nisak Muhammad Yusof, PhD, Putra Malaysia University.
And Dr. Dwi Prihatin Era, Health Polytechnic, East Kalimantan, Indonesia.
The Honorable Deputy Director of Health Polytechnic of East Kalimantan, along with all staff.
The Honorable Head of Provincial Health East Kalimantan.
The Honorable Director of Hospital, Head of Health Education Institution.
The Honorable Head of Department and Study Program of Health Polytechnic of East Kalimantan.
The Honorable Lecturers and Educational Personnel, as well as all the webinar participants that we are proud of. Assalamualaikum warahmatullahi wabarakatuh.
All praise and gratitude belong to Allah Subhanahu wa Ta'ala, who has been giving us guidance, healthiness, and happiness to hold our occasion. The first is Borneo Health International Conference with the theme
Driving Innovations in Healthcare by Receiving Health Education, Virtual Healthcare Response to COVID-19 Pandemic. This webinar is organized by Health Polytechnic of East Kalimantan with more than 500 registered participants and supported by Bank Syariah Indonesia.
Ladies and gentlemen, let's begin our conference by reciting Basmalah.
Bismillahirrahmanirrahim. Singing Indonesian National Anthem, Indonesia Raya, and Hymn of Health Polytechnic of East Kalimantan. To all audience, please stand up. Audience, please be seated.
In order to have our conference run conducive, let us invite Mr. Dani Sartika, Bachelor of Computer, to lead us in prayer. To Mr. Dani, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Surah Al-Fatihah. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Arrahmanirrahim. Maliki. Iyyaka na'budu wa iyyaka nasta'in. Ihdinas siratal mustaqim. Siratal ladzina an'amta 'alaihim ghairil maghdubi 'alaihim waladdallin. Amin amin. Alhamdulillahi rabbil alamin. A'udzu billahi minasy syaithanir rajim. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Wa bihi nasta'in ala umrid dunyad. Wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Amma ba'du. Allahumma antas salam wa minkas salam wa alayka ya'udus salam. Tabarakta Rabbana ya dzal jalali wal ikram. Ya Allah, ya Tuhan kami, atas izin-Mu kami berkumpul di ruang ini dan di ruang Zoom hari ini untuk melaksanakan the first Borneo Health International Conference Poltekkes Kemenkes Kaltim. Seraya menundukkan kepala untuk berdoa kepadamu agar kegiatan pada hari ini mendapatkan keberkahan dari-Mu ya Allah. Ya Allah yang Maha Pemurah, limpahkan hidayah-Mu, anugerahkan kepada kami rasa sayang, saling pengertian, saling menghormati satu sama lain. Berikanlah keikhlasan dan kesabaran kepada kami dalam menjalani kehidupan kami. Ya Allah yang Maha Penyayang, karuniakanlah kepada kami, kepada Poltekkes Kemenkes Kaltim ini, keimanan dan ketakwaan serta menjadi gudang ilmu yang bermanfaat sehingga kelak menjadi amal jariah dan berguna bagi nusa bangsa dan agama. Ya Allah yang Maha Kuasa, angkatlah derajat kami, tempatkanlah pada derajat yang lebih tinggi, lebih luhur, sebagaimana Engkau mengangkat orang-orang yang terdahulu, dan jadikanlah sifat tawadu di dalam diri kami ya Allah. Ya Allah, ya Tuhan yang Maha melindungi di tengah wabah COVID-19 yang masih berlangsung sampai detik ini, semakin menyadarkan kami betapa lemah dan kami tanpa pertolongan-Mu. Karenanya ya Allah, dengan kuradat dan iradat-Mu, mohon Engkau berkenan mengangkat wabah ini dari dunia ini. Sehatkan, kuatkan, dan tabahkan kami dalam menghadapinya. Ya Allah yang Maha Bijaksana, hanya kepada-Mu lah kami bergantung. Kami memohon pertolongan, tiada kuasa selain atas izin Engkau, maka kabulkanlah doa kami. Allahumma inna nas'aluka salamatan fid din wal afiyatan fil jasad wa ziyadatan fil ilmi wa barakatan fil rizqi wa taubatan qablal maut wa rahmatan indal maut wa maghfiratan ba'dal maut. Allahumma hawin alaina fi sakaratil maut والنجاة من النار وعفوا عند الحساب. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. سبحانك رب العزة عما يصفون والسلام على المرسلين والحمد لله رب العالمين. والسلام عليكم ورحمة الله وبركاته.
Ladies and gentlemen, without further ado, we would like to invite to the podium for given information about his report. As a chief of this webinar, Mr. Nursrifan Firdaus, Master of Health, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, and may the peace will always be upon us. The Honorable Head of Health Human Resource Education Center of Health Ministry, Republic of Indonesia, Mr. Dr. Sugianto, and to our honorable speaker today for four countries. The first speaker is from Naohiro from Japan, and second speaker is Dr. Afsal Mahmud from Australia. The third one, Barakatun Nisa, PhD from Malaysia, and the last speaker, Dr. Dwi Breten Ara from Indonesia, from Politeknik Kesehatan Kalimantan Timur. The Honorable Director Health Polytechnic of Health Ministry is Kalimantan, Dr. Haji Supriyadi, Magister of Nursing, and also the Honorable Deputy Director of Health Polytechnic Health Ministry is Kalimantan, alongside with of the center, head of unit, head of department, head of program studi, lecture, and all sivitas akademika in Politeknik Kesehatan. And the Honorable main sponsor for today from Bank Syariah Indonesia, thank you very much. Give support in this event, and the Honorable all of stakeholder, health service, hospital director, leader from health institution in Kalimantan Timur, and for all participants in this event in Mercure Hotel or in Zoom or in YouTube channel in Poltekkes Kalimantan Timur. First all, may I express my gratitude to Allah Subhanahu wa Ta'ala for all His blessing, so that we are even able to present in the international conference. We as committee would like to express our appreciation and gratitude to all participants for generally in attending this international conference or seminar international. Also, I am sending huge appreciation to all commit to all team can make this event. Thank you very much. Until this night, until today, I hope and I say thank you very much. And then we, the academic from Health Polytechnic Kalimantan Timur, as an excellent public health university, feeling responsibility to create this event. Like title in my bag, drive innovation in healthcare by reshaping health education, virtual healthcare response to COVID-19 pandemic. This international seminar and conference is being held on site in Mercure Hotel, and this is blended online and offline. Online in Mercure Hotel, offline, and online from Zoom and from YouTube channel from other countries, especially is Indonesia. The participant in Zoom and offline and online until 625. Give applause to all participants. And this is consists of student, lecturer, and expert in healthcare. And then for internal conference, the participant from Indonesia and as 20 oral presentation and 3 poster. Finally, I hope this event can give information, can give motivation for all, especially for we Politeknik Kesehatan, because we have sumber daya manusia is luar biasa. I think this is can make different from Indonesia. I think it's can I say, and thank you very much for participant. Thank you very much for my team, and thank you for all of. And assalamualaikum warahmatullahi wabarakatuh. Good morning.
Thank you, Mr. Rifan Firdaus, for the report. And we would like to invite our Director of Health Polytechnic of East Kalimantan to deliver a welcome speech. Please welcome Mr. Dr. Supriyadi, Bachelor of Nursing, Master of Nursing.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon everyone. Bismillah, alhamdulillah, wassalatu wassalamu ala rasulillah wa ala alihi wa sahbihi wa man walah, amma ba'du. The Honorable of the Head of Staff of the Board of Development and Empowerment Human Resources, Dr. Sugianto, Master of Life Science, the Honorable of the Deputy Directors in Health Polytechnic East Kalimantan, the Honorable, the all speakers, the Honorable Rector and Director of all health education institution in the province of East Kalimantan, the Honorable the Director of Hospital in the province of Kalimantan, the Honorable the Head of Professional Association and Organization, the Honorable the Head of Study Program in Health Polytechnic East Kalimantan, all staff in Health Polytechnic East Kalimantan, the Honorable main sponsor for these today's events, Bank Syariah Indonesia, and all participants of international seminar who have participated in this international seminar through Zoom rooms. At the first, let us thank to God, Allah Subhanahu wa Ta'ala, who give us the healthy so we can gather in this place. Moreover, let us praise, salawat, and greeting to the Prophet Muhammad Sallallahu Alaihi Wasallam, who has brought us out of dark age to the bright age of today. Ladies and gentlemen, today is 23rd October 2021, and the COVID-19 pandemic has still not ended yet. However, we must happy and grateful because we have gathered here to carry out this international seminar with theme driving innovation in healthcare, strengthening health education, virtual care, and reshaping healthcare in response to the COVID-19 pandemic. This seminar is also a program from the Division of Research and Community Education in Health Polytechnic East Kalimantan. Ladies and gentlemen, Indonesia is an archipelago country which has impact on the difficulty of reaching access to health services in some remote areas. This condition causes low level of awareness about health among community. This case has been started from education. In this world, health services need skill training so they can give the best treatment for all patients. As the result of the COVID-19 pandemic, many learning activities and practical works must be postponed. The greatest impact in felt for sectors that use practical works to develop the ability in the professional world. The development of current technology affects to maximum health services to support the efficiency of resources and finance. The health world has been a profession that has an important role in technology-based health services. The use of this technology is applied to home care services to provide sustainability nursing care. Various innovation in health services continue to be developed, where innovation is one of the important elements that must be explored continuously so that the purpose of education can be achieved. In other words, the purpose of education is to provide equal right of education for all people and optimum quality of health services. In this pandemic era, innovation is not only a way to tackle the spread of the virus, but also we can keep to give health services with the most safest way. Ladies and gentlemen, nowadays we enter the era of PUCA. PUCA stands for volatile or always change. It's meant the dynamic of rapid environment change. Uncertain or not clear means that we must act with uncertain circumstance. Complex or complexity means that we live in a dynamic, a lot and interdependent environment. And ambiguity means that we live in unusual environment and beyond expertise. Therefore, various health efforts must be carried out in a comprehensive, tailored, and integrated manner. To support the success of this health development, various programs of health innovation are necessary to do. The COVID-19 pandemic creates high demand for health institutions they look for ways to survive and bring sustainable innovation for community quickly. However, this crisis might still be far from over, and the ability to innovate in health services must be improved to meet the challenge present by both COVID and economic constraint. Innovation in health services is a commitment of support between innovators and institutions to overcome the global COVID-19 pandemic. The COVID-19 pandemic has encouraged technological innovation in the health sector through telemedicine services. This is one of agendas in accelerating digital transformation. Telemedicine is a long-distance health services, allow patients and health workers to communicate without having to meet face-to-face. Ladies and gentlemen, according to some topic in this seminar, we present the speakers who are truly competent, both as academics and practitioners. The topic raises also the latest issues in the health sector, which are certainly interesting and important to study. The first speaker, Professor Dr. Naohiro Hohashi from Kobe University, Japan. The second speaker, Dr. Abjal Mahmud from Adelaide University. The third speaker, Barakatun Nisak Yusuf, Muhammad Yusuf, PhD from University of Putra Malaysia. And the fourth speaker, Dr. Dwi Prihatin Era, Magister Keperawatan from Indonesia, especially Health Polytechnic is Kalimantan. Through this seminar, we hope that it can improve our knowledge about the effort that we can do to optimize health services in Indonesia, especially for each region or province. Moreover, current innovation are supported by advanced technology and a lot of information from many sources, so that we hope there will be more new innovation from health workers. We are very grateful to the participants who have enthusiastically participate in this seminar. I also thank to all speakers who have spared their time to share their knowledge to us. And thank you to all deputy directors, the head of division and the head of study program in Health Polytechnic East Kalimantan, and all committee of this seminar. I hope that this seminar will provide many benefits, especially in updating information about health services for all of us. Amin ya rabbal alamin. Sukses for Health Polytechnic East Kalimantan, and thank you for today. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Supriyadi, for the welcome speech.
Ladies and gentlemen, next we would like to invite the head of Health Human Resources Education Center, Ministry of Health Republic of Indonesia, Dr. Sugianto, Bachelor of Education, Master of Applied Science, and will officially begin our conference. Please welcome the Honorable Mr. Dr. Sugianto.
Good morning and greetings.
Good morning.
It is my privilege to address you, faculty member of Health Polytechnic Kalimantan Timur, distinguished speakers, participants to this webinar. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semua. First of all, I want to give my gratitude and my appreciation to Health Polytechnic Kalimantan Timur for organizing this webinar. Before we begin, let's pray with the praise to Allah Subhanahu wa Ta'ala, the Almighty God, for all the grace and guidance that has been lavished upon us. Only with His blessings we can gather here in good health so that we can get together on this international seminar held by Health Polytechnic Kalimantan Timur. Dear distinguished guests, ladies and gentlemen, Indonesian health services must be adaptive in dealing with the COVID-19 pandemic situation. This is in line with the President's vision and mission. The Ministry of Health will transform the health system from 2021 to 2024 to create a healthy, independent, productive, and equal society with 5 outcomes and 6 pillars to focus on. The 6 pillars of health transformation are the transformation of primary services, the transformation of referral services, the transformation of health resilient system, the transformation of health financing system, the transformation of health human resources, and the transformation of health technology. The 6 transformation aspects are divided into 2 categories, namely the main program category with 3 transformation aspects. Also, 3 other aspects fall into the category of fundamental enablers. First, the transformation of primary care that focuses on creating healthy people and focuses on preventive measures. At this stage, it will cover population education, primary prevention, secondary prevention with health checks, and increasing the capacity of primary services by bringing primary and community-based services closer together. Then the second transformation in secondary healthcare, where all hospitals provide the best and standardized services through the country. Then the third transformation is the aspect of health resilience system. This is done by increasing the resilience of the pharmaceutical and medical device sector. For example, the availability, access, quality, and affordability of pharmaceutical and medical equipment. In addition, by the strengthening the resilience of emergency response, for example, disaster response preparedness. Then the other three aspects fall into the category of fundamental enablers, namely the transformation of health financing, the transformation of health human resources, and the transformation of health technology. Health system can only function with health workers. The foundation for a strong and effective health workforce, able to respond to the 21st century priorities, require matching effectively the supply and skills of health workers to population needs, now and in the future. To achieve RPJMN indicators 2020 to 2024, Ministry of Health launched transformation of health human resources by increasing the quantity, distribution, and quality of health workers through scholarships, empowerment of health diaspora, and exchange of health professionals with international partners. The priority projects in supporting the implementation of priority activities related to the transformation of health human resources are carried out by fulfillment and equitable distribution of health human resources, fulfillment of 9 health workers at Puskesmas through special assignments, fulfillment of specialist doctors at hospital, RSUD, and empowerment of Indonesian foreign graduates health workers. Health human resources competency, improvement and training, including education and training of health workers, scholarship for prospective doctors, specialists, health workers, and health human resources. Development of health functional positions and health human resources careers by strengthening the management of functional position and career development of health workers in private health facilities, providing JKN services. Ladies and gentlemen, and our respected guests, the global crisis caused by the COVID-19 pandemic has created unprecedented hurdles of Indonesia's development goals. The challenges faced during the COVID-19 pandemic are healthcare system. During the COVID-19 pandemic, the healthcare system underwent changes such as delays in essential services, including maternal and child health services, infectious and non-communicable disease services. On the other hand, there has been an increase in demand and surge capacity for several types of services related to COVID-19, namely the need for ICU rooms, isolation rooms, and an increase in the need for health workers. Minimize the risk of infection in staff and control the risk of infection in teaching hospitals, because one of the biggest challenges in handling COVID-19 is the high rate of transmission of COVID-19 to officers in healthcare facilities. Providing quality services. Quality of services is critical to adapting activities in a pandemic while ensuring continuity of essential services and ensuring an effective response of COVID-19. When the relaxation of policies and the implementation of preparatory activities and hospital accreditation surveys, guidelines are needed so that the commitment of hospital leadership in maintaining and making effort to improve quality can be fulfilled. Prioritizing the continuity of essential services during a pandemic situation so that there is a balance between fulfilling the handling of COVID-19 and routine health services. Another challenge is how to ensure the role and function of educational hospitals in the provision of health services. Education and research, which will determine the competence achievement of students in the fields of health, continuing education, and other health education. Since the beginning, the government of Indonesia has implemented a strategy to deal with the COVID-19 pandemic. First is detection. This can be done through several activities, for example, increasing testing throughout Indonesia, increasing tracing for close contacts, and genomic surveillance strategies for early detection in new strains of SARS-CoV-2. Secondly, therapy that can be done with several activities, including increasing self-isolation monitoring and self-centeredness, ensuring the availability of hospital services like beds, health workers, medical devices, and medicines, conducting clinical trial research. And the third strategy is vaccination, which includes several actions, such as ensuring vaccine availability and cold chain logistics, ensuring good distribution of vaccines, accelerating vaccination, vaccination centers like vaccination centers, vaccination gotong royong, or private. The strategy for handling the pandemic in Indonesia require the support of a strong health system through strengthening the implementation of health protocols and strengthening the national health data and information system. The government has drawn up a draft strategy for handling COVID-19 for 2022. Implementation of testing, aimed at suspect and close contact for 28 million people, or 58 million people. Vaccination for 77% of the population, plus a booster. Provision of care for moderate and severe cases, isolation facilities for asymptomatic cases, research efforts for genome sequencing, local production of vaccine, and clinical trial of COVID-19 drugs. Bapak, Ibu, hadirin sekalian yang saya hormati. In the midst of swift flow of information dissemination, literacy skills are needed to understand and process this information. There are various types of literacy that have been developed which are useful in helping people understand various information, one of which is health. Health literacy as a person's ability to obtain, understand, and process information and health services needed to take health appropriately. From this definition, it can be seen that if someone has a good level of understanding of health literacy, they can apply the information they get in their daily life. Consciously or unconsciously, health literacy has become a solution to health problems in society. For example, when reading instruction for drug use, conducting medical consultation with doctors, following procedures during exercise, etc. With good health literacy can be used as a medium for building the condition of a community together. By increasing the level of understanding of health problems and supported by social activities that involve the community activities so that people can participate and practice it in their daily lives. Apart from being a solution to health problems, health literacy is also able to become a bulwark for the community to avoid the threat of existing hoax. It is globally and digitally interconnected world. All kinds of healthcare workers must deal with the challenge during the pandemic. Universal topics like 21st century skills using technologies, leadership, intercultural competence are connected to this global pandemic. In this changing world, we are facing more and more complex problems, since these pandemics may have a series of outbreaks. It is expected to have different phases where we need to react, then realize and reflect on the essence of the sudden major life challenges. These changes in our world are having a direct impact on the medical industry. The 21st century has the most advanced medical technology compared to any previous century. But it is also has unique problem that make it necessary for healthcare to adapt. For health workers, shortage to changes in healthcare technology. Healthcare industry are working hard to be prepared for the changing needs in the medical community, especially in this COVID-19 pandemic. Qualified and trained health workers leadership is crucial to ensuring that healthcare facilities are able to keep up with changing needs for the industry. As more individuals become qualified to lead and in the healthcare field, more minds will be at work to help tackle challenges and problems. With fourth largest population in the world, Indonesia has a potential in the development of digital health technology. The technology is expected to facilitate the people of Indonesia to gain health access more easily, which will be a benefit for more than 260 million people who live in more than 70,000 islands spread in the country. The digital revolution in health sector is driven by e-health development and innovation, which leads to the approach that enable the user to share and looking for latest information. Long-distance consultation with medical practitioner, which include prescribing and sharing patients' health documents sharing. The digital health development will lead to open health technology, where the user are able to have open access to more convenient ways in approaching health services. The spectrum of digital services in the field of healthcare in Indonesia is vast. Hence, it has been classified into three major segments. One is e-pharmacy market. In 2020, e-pharmacy players made up 3% of Indonesia pharmaceutical sectors. E-pharmacies could play a bigger part as social distancing has forced many consumers to adopt and become accustomed to its services. Second, online consultation and appointment booking market. By March 2020, digital healthcare providers have witnessed more than 61 million patients visit their website for virtual medical assistance. And the third, healthcare IT solution market. A rapid growth of Indonesia digital health ecosystem opened the opportunity for software developers to tap into these emerging sectors. Indonesia has hospitals, clinics, and pharmacies and become the end user for healthcare management system, medical practice management software, as well as electronic medical records to provide their own digital health solutions. It is quite evident from the growth in these three segments that Indonesia is witnessing a shift from traditional to online health services. International businesses entering the market can contribute toward its growth in the future. Bapak Ibu, ladies and gentlemen, webinar participants, before I end this speech, I would like to thank to those who have participated in this webinar. I am sure today we all gather here with the same mission to overcome the health crisis we were already living and respond to the pandemic we are all facing. The challenge is to reduce as much as possible the negative impact this pandemic will have and build on this experience to get improvement in the way of living. Bapak Ibu sekalian, mudah-mudahan kegiatan seminar webinar ini berjalan dengan baik, dengan lancar, tidak ada kendala, dan bermanfaat untuk Poltekkes Kemenkes Kaltim, bermanfaat untuk masyarakat Kaltim dan masyarakat Indonesia. Mudah-mudahan kegiatan dari awal sampai akhir berjalan dengan sukses dan memberikan kontribusi nyata bagi masyarakat kita. It has been an honor to be among such accomplished individuals who present best practice and experiences in driving innovation in healthcare, strengthening health education. Bapak Ibu sekalian, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Okay, thank you, Mr. Dr. Sugianto, Bachelor of Education, Master of Applied Science, for officially opening this conference. Ladies and gentlemen, now to all the participants, our next agenda is presentation from our main speakers. But before our speaker give the presentation, I would like to say for all participants, you have to make sure your microphone is mute and your camera is on, so we can hear on our keynote speakers clearly.
The question will be recaps and answered after all of the keynote have presented the presentation, yet the participant could write the question in our comment section on Zoom or on our YouTube live chat section. And to the invited guests and the participants who will present at the venue, we invited you to enjoy a coffee break and thank you for attending the opening of this conference. Kepada seluruh tamu undangan yang hadir di venue Mercure, dipersilahkan untuk menikmati coffee break dan konferensi akan segera kita lanjutkan.
The plenary has 4 sections. The first and second section will be led by Dr. Edi Sukamto, Master of Nursing, with 2 our incredible speaker, Naohiro Hohashi, PhD from Japan, and Dr. Afzal Mahmood from Australia.
And the third and fourth session will be led by Mr. Isman Shah, Master of Nursing, with the main speaker is Barakatunisah Muhammad Yusuf, PhD from Malaysia, and Mrs. Dr. Dwi Prihatin Era from Indonesia.
Okay, let's welcome our first moderator, Dr. Edi Sukamto, Master of Nursing.
Thank you.
Hello, Dr. Edi Sukamto.
Hello.
How are you today?
I'm fine, thank you. Thank you for the chance given to me to lead this session.
Okay, you are welcome. Okay, Dr. Edi Sukamto, time is yours.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. On behalf of the committee of the first EBHIC Borneo Health International Conference, may I welcome and thanks for joining in this seminar. The theme of this conference is driving innovations in healthcare, strengthening health education, virtual care, reshaping healthcare in response to COVID-19 pandemic. But the first of all, we all apologize because our seminar delay around 30 minutes because any technical problem. And as you know that this seminar, there are 4 sessions. 2 sessions must be led by me, Edi Sukamto, and the second step, session number 3 and 4, led by Mr. Isman Shah, Master of Nursing. And now, for the first session, we welcome from Professor Naohiro Hohashi from Division of Family Healthcare Nursing, Graduate School of Health Science, Kobe University, Japan. Hello, Mr. Professor Naohiro Hohashi. You already there? Good morning.
It's noon now. Okay.
It sounds clear?
Pardon?
It sounded clear?
Can you hear me?
Yes, I can hear your voice.
Yes, but sound is howling now.
Oh. Technician, please. Smaller echo. Okay?
and occupational therapy, music therapy. They use therapy. So I use therapy in the family healthcare nursing. So family healthcare nursing is one of the therapy for family. Family healthcare, this shows family nursing theory. What is nursing theory? It means a consistent concept and definition, proposition for describing family phenomena and providing explanations to make possible predictions and control. Theory has two aspects. One is describe family phenomena. It is very important. Family nursing theory explain what happened to the family. But more important aspect is provide, make possible predictions and control. So family nursing theory can control family problem. So if we use nursing theory, we can control and solve family problems. So we must use theory for family support. According to the breadth of applicable family phenomena, this can be divided into three types. One is the ground theory, and middle range theory, and practice theory. But the middle range nursing theory is very important because it is not so abstract and not so concrete. So it is very applicable to many family phenomena. So in Japan now, about 5 years ago, many books about middle range theory is published. So we use middle range theory for nursing practice. This slide shows what is practice and theory. This shows the suspension bridge. The pillar is the evidence. Pillar is the evidence. And cables is the theory. And the path here is the practice of the practice for support for practice of support for families. So theory and evidence from research can make possible best practice. So we use evidence and theory to support family. To realize practice of high-level support for families, it is essential for it to be backed up family nursing theory, evidence, and also experience. This explains that if we have theory and evidence, we cannot practice family support. We need experience. Okay. And the fusion of theory and practice is very important. Without theory, there can be no practice. And without practice, there can be no theory. The key to realize the combination of understanding theory and be capable practice it is very important. I'm a theorist, and I proposed many theories in family healthcare nursing. This slide shows the three major theories proposed by me. One is the concentric sphere family environment theory, CSFET, and family caring theory, FCCT, and family belief system theory, FBST. These theories is called three major theories, okay? And this paper shows the development of concentric sphere family environment theory. The modern theories is developed by evidence, not practice, not experience, okay? The modern new theory is based on evidence and research. The old theory is based on experience, but new theory is based on research and evidence. Okay, this slide shows the explanation of CSFET. CSFET is a middle range theory proposed by me 205 that focus the family environment that acts on family well-being by taking up the family system unit from the chrono and spatial axis and aiming for holistic high-level family existence. Okay. And CFT is based on scientific research. And this family is in the USA. This family is in China. And this family is in the Philippines. And this picture taken at the Indonesia, Riau province, okay? I'm doing the ethnography in many countries and regions and develop these theories. And development of the concentric sphere family environment theory, I'm doing research using ethnography in many countries and regions. And, sorry, doing the ethnography, over 1,050 families and over 90,000 questionnaire surveys. Based on this ethnography, I developed this theory. This is a brief explanation of my theory. This theory is very special because this theory this theory, how to say, explain the family environment which expands externally and internally. Externally means outside of the family, and internally means inside the family. It is the family members. So many family nursing theory is focused on the internal family members, the relationship between family members. But my theory is focused on not only family members, but also outside the family. Okay. This is a map of my theory. There is 3 assessment axes: structural distance and functional distance and temporal distance. These are assessment axes. And inside the space and time made by 3 axes, there are 5 systems: suprasystem, macrosystem, microsystem, suprasystem, macrosystem, microsystem, and family internal environment system, and chron system. As I explained, theory can predict future. So this theory has a chronos system. This explains the terminology of my theory. Structural distance means the existence of family environment, and functional distance means condition or psychological separation from the psychological subjective perspective. And temporal distance, temporal means the time. This means the transformation process of family system unit and family environment. This is a change and time chronological perspective. Okay. And in the concentric family environment theory, family rules and beliefs, these are the assessment items. 43 assessment items, family items, are inside of this theory. These are 43 assessment items. And the entirety of family system unit is established by the adaptation of family to the family environment. This makes family well-being, and family well-being can be realized. So the CSFT is a middle-range family nursing theory. So it is easy to make assessment model and intervention model. So CSFT has a assessment model, FEAM, and care caring model. This care caring means intervention model. And assessment model and care caring model is also already developed. Okay. Its use makes possible a comprehensive approach from within and outside of the family environment that acts upon family well-being. It establishes a ground design for family nursing and armed with the theory, enables family support based on evidence and phronesis. This is an explanation of the assessment model. There are two types. Blue one is family observation and interview, and green one is a measurement tests. Family observation and interview is a qualitative approach, and measurement test is a quantitative approach. So the family is very complicated. We provide nothing to the individual, but family is composed of many family members. So it is important, it is difficult to gather data of family and make assessment. So we developed qualitative and quantitative method to assess family. Yes, qualitative and quantitative. The results from both. Okay, and one of the characteristic assessment model is conduct family assessment through the mixed methods, qualitative and quantitative. Okay. Family observation and interviews. This slide shows the qualitative methods. This blue one, there are composed of family environment observation interviews and memo and map. This family environment map is just like a genogram and shows the relationship between family members and outside the family. Family environment assessment index, a checklist, and a chronological table, and health assessment of family members. We use these tools to assess family qualitatively. The name of this tool is here. And the measurement test is green one. This is composed of family environment and survey of family environment. This is a tool to assess family functioning and family sociographic module and time allocation module, family growth and development module, family resource module, and family symptoms module. We deliver this questionnaire to family, and we can gather family data quantitatively. And red one is a combination of family observation and interviews and measurement tests. And we opened a CSFET-based family nurse consultation unit. In 2017, CSFET-based, this is the name of my theory, CSFET-based family nurse consultation service unit was opened as Japan's first family nursing clinic. Because in Indonesia, nurses can open clinic, but in Japan, it is prohibited. But I want to provide family nursing support to the local communities. So I negotiated with the university for over 6 months. First, they denied because in Japan, nurse cannot open clinic. But I persuade them, and finally I could open the clinic. But there are many limitations. They say that the next slide. This shows the types of consultation is limited. Only the research I did. If I did research and I have evidence, I can do consultation. But there is no evidence from my research. I cannot provide consultation. So the 1, 2, 3, 4, the types of consultation limited to 4 types. It is free, and it is operated using social media and Zoom. In Indonesia, Line is also available, and Zoom is available. So I'm providing nursing care to mainly in Vietnam and the Philippines, and sometimes in Indonesia, okay, using Line or Zoom or Messenger. What is the CSFT-based family nurse consultation unit? It's based on the CSFET and providing high-level support to families and thereby promoting family happiness and family functioning. What can CSFET trained nurses do when providing family consultations? We provide care by 2 nurses, not only 1 nurses, because family problem is very complicated. So we provide care to families by more than 2 nurses. Take responsibility to listen to family difficulties with all consultation held in complete confidence from outsiders. So this is the flow of our consultation. Appointment, initial meeting, clarification of family problems, creation family assistance plans, follow-up meetings. Client, this shows what is the client, days of the week, only weekdays and Saturdays, hours of operation from 9 a.m. to 5 p.m.
Kepada Bapak Ibu tamu undangan yang hadir di ruangan ini, apabila ada
someone talking. Location at our university or the subject's home or other location where privacy can be maintained or conducted remotely via social software or video conference software. And as I said, types of consultation is limited to these types. And this slide shows my small research concerning the efficacy of virtual family interviews, meetings that transcend family distance and national borders. First, this is the background. Due to novel coronavirus pandemic, an emergency was declared in Japan for the period of last year. During this time, people requested to stay at home, and as a result, this situation, economic activities were considerably curtailed. In Japan, now the coronavirus is not so big problem. In Tokyo, last day maybe only less than 10 new cases in Tokyo area. So now many people don't wear masks now. Maybe many Japanese go to abroad now. In our university, now over 30 students are planning to go to abroad to study. But maybe 3 months before, the corona is a problem. So with family members spending more time together, household budget are adversely affected, even leading to so-called corona divorce, as well as more cases of domestic violences. In Japan, after staying at home last year, the cases of divorces were increased. It is because of the Japanese nationality. In Japan, husband work outside the home for a long time, and staying at home, if husband staying at home for a long time, the husband and wife's relationship becomes worse. It is a traditional pattern, maybe over 50 years ago. Wife hopes that husband is healthy and outside the family, outside the home. So the coronavirus makes the husband stay at home. So the cases of divorces increasing. And also the domestic violence is increasing. In addition, families' anxiety related to pregnancies and childbirth and so on resulted in more family-related problems. Okay. To resolve such problems, family interviews and meetings are effective. But in many cases, face-to-face meetings cannot be arranged. So distancing open up via internet can be expected become new normal. The objective of this study is to share experiences of virtual family interviews meetings utilizing Zoom video conference software and Messenger social software. This is a method. Interviews and meetings are planned utilizing the family environment map. This is one of the qualitative tools of my theory, Family Environment Assessment Index and others based on the concentric sphere family environment theory. The objective was to conduct assessment of family spirituality, which is defined as a set of core beliefs of the family system unit that cognize the meaning of existence of the family system unit in a transcendental dimension. Interviews and meetings were conducted with 8 Japanese families utilizing Zooms and 2 Filipino families utilizing Messenger. Through debriefings, skills are refined. This research was conducted with the approval of the IRB of our university. This is results. The family interviews and meetings, which lasted for 2 hours, were conducted between May and June 2020. The FEM, utilizing Zoom's whiteboard function to perform mapping with a touch pen by which basic family basic family data were collected. This is a whiteboard of the Zoom, and we are gathering family data here and writing. Next, utilizing specific killer questions developed from the FEAI. FEAI is one of the tools based on CSFET. Effective data collection and organization was conducted. Immediately afterwards, we asked the subject about their opinions. As one topic, families replied that holding a discussion without eye contact was difficult, felt fatigue. The nursing professionals voiced such as opinions as it was difficult to register the thoughts of the subject, and obtaining family data by a computer screen had limitations, and so on. Advances included that families felt less threatened as compared to the face-to-face meeting. It was convenient for those with difficulty in going outside, and so on. The nursing professionals voiced such opinions as they had been able to communicate better than anticipated, and that they were able to obtain frank responses to typically uncomfortable questions, and so on. Moreover, no incidents or accidents were observed in terms of safeguarding of the privacy of family data. This is a discussion. Virtual family interviews meetings enable actual exchanges with families, but because the same space was not shared, the inability to maintain a sense of presence was an issue. As many people in Philippines utilize smartphones, they did not appear uncomfortable with family interviews meetings. But in Japan, we use smartphones, but not so frequently. We use Zooms or messengers. So in Japan, it is one of the problem. However, as less family data tend to be obtained, some measures need to be devised so that family assessment will not be made more difficult. Consequently, some degree of IT literacy is important when conducting virtual family interviews and meetings. This is a conclusion. Virtual family interviews and meetings do not represent a full substitute for actual family interviews and meetings. In environments where actual family interviews and meetings are not possible, virtual family interviews meetings should be conducted with an understanding of their limitations. For virtual family interviews and meetings to be effectively utilized, an intermediate or advanced level of IT literacy is prerequisite. And next, I will explain the support for families based on religions. This is explanation of religions. Religion is teachings of salvation through beliefs in supreme beings and Buddha and others. The three major religions of the world are Christianity, Islam, and Buddhism. In Indonesia, many people's religions are Islam. In Japan, we are Buddhist. So we have a different religion. And this is a new approach for families, nursing through Buddhism. Maybe this is applicable for Islam based on the teachings based on the Islam. Through my experience of many sufferings, so the I found that the importance of spirituality. And I have also confronted the negative legacy created by science. And I came to understanding the true nature of Buddhism. I am not so interested in religion. Japanese are not religious people. So over 70% Japanese don't have religion. We don't believe in religion. Only maybe 20% of Japanese are religious, less than 20%. So almost all Japanese are not so religious. But so I don't know what is Buddhism, but I found that teachings of Buddha is make living person to attain happiness. So this is now I am a priest. This is the name of the ordained priest name. Nothing through Buddhism is defined science that practice nothing through the application of Buddhist wisdom. Buddha taught that Buddhist seeks liberation of the four sufferings. Four sufferings means birth, aging, sickness, and death. So if we use Buddhism, we can relieve and solve problems about birth, especially aging, sickness, and death. And Buddha's preaching deals with how to live while alive. The Buddha don't explain after death. Buddha explain only living life. According to the Buddhists, one of the first bring relief to those who suffer in order to free oneself from one's own early desires. Through application of family nursing, both the targeted family and nursing professionals themselves obtain relief in the same manner. So I'm bringing about a blessed universe that transcends religion, uniting the forces or branches Shingon. Shingon is one of the branch of the, Shingon is one of the branch of the Buddhist in Japan, as well as Buddhism sphere. All Buddhism in its entirety. This is my name. This is a Dera means a temple. So priest Taketsu is my name, priest name. I have a cyber temple operated by me. And I explain what is nursing through Buddhism. One is sermon therapy, a consultation place for heart and life. Everyone has concerns and anxieties, so people should not take them all on themselves alone. And distant consultation can range utilizing Zoom or Line, and all matters are treated strictly confidential. And I listen to the problem of the family, and I explain the teachings of the Buddha, and they remove anxiety.
Excuse me, sir. 5 minutes more.
Okay, I see. Thank you. They can solve their problems. This is a sermon therapy. And meditation therapy. Ajkan is one of the methods of the Buddhist. So meditation is performed while looking at the Sanskrit character A. So this is, we call it Ajkan. This therapy has a favorable effects on body, mind, spirit, and can be effective in relieving stress and worldly concerns. And next is the sound therapy. Sound therapy is described including shomyo. Shomyo is a Japanese Buddhist music with rhythm and intonation. Medical sounds developed by me. I'm selling medical sounds, and this is developed by me. And singing bowls and tuning forks. And other methods. Nothing through Buddhism also can be available, a variety of other methods of treatment. So I am providing sermon therapy, meditation therapy, sound therapy, and other methods to families to solve their problems. And this is the references of my presentation. This is the development of the CSFET and caring theory, development of the caring theory. And this is beef theory. And this paper describes establishing transcultural family healthcare nursing. This is the contact information. And this slide shows this QR codes shows the website, my website. This concludes my presentation. Thank you so much. Do you have a presentation file on me? I will send the presentation file and the papers to you by chat box. Okay?
Yes, of course. Thank you.
Okay. Thanks so much.
Okay, thank you, Professor Naohiro Hohashi,
Yes.
for an interesting presentation.
Thank you so much.
As I can see, there are 4 main issues in your presentation. The first, family healthcare nursing is practice of nursing that focuses on family healthcare nursing, with also preventing and therapeutic act to help the enabling self-actualization of the family system unit. The second one, which have 3 major theories. The first one is the concentrate spare family environment theory, or CSFET, which is a theory that focuses on the family environment, direct on family well-being by taking up the family system unit from the chrono and spatial axis, structural distance, functional distance, and temporal distance, with the final goal of increasing the level of holistic family existence. The third one, the second of theory family care, caring theory, is VCCT, is a practical theory of nursing that have 2 main points, which are the family environment assessment model and family environment care caring model, that we can connect with our first theory about concentrate spare family environment theory. By using the tool that concentrate spare provide, that we can use as a guideline to assess and giving implementation of nursing. The last one, the third theory, family belief system theory, FBST, religion forms the basis of human culture in a variety of forms, including ideology, language, and social customs. As healthcare providers, we should have some knowledge about the religious need and use the values of the religion itself to increase the quality of health care that we give. And your experience using the technology of information to deliver the health services to the family. Is right?
Yes.
Okay, ladies and gentlemen, that would be all for comment and clarify, even just 15 minutes more. It's time to us to discuss. Perhaps there are any questions. Please address your question, whether on site or online Zoom. And before asking you question, please state your name and your institution clearly. And proudly, Professor Naohiro Hosashi will be answered. Right, sir?
Okay.
Okay, please. Maybe any question? 15 minutes for discussion. Okay.
Andy Sutuano-san. So she is raising hands. Andy Stanto. Miss Andy Stanto?
Very good morning, sir.
Yes, please.
Hi.
Hi, sir. My name is Andy. I'm
Andy.
from yes. I am alumni of a Polytechnic team. I work in the police institutions right now, and I would like to ask about the religion form that you have already explained through your presentations, and it is very, I think, very wonderful. And I would like to know for your version, according to the Indonesian, as we know that Indonesian people are very complex with the religions. You know, we have 6 religions officially in Indonesia. So, according to your opinion, based on your opinion, how do you prepare for the online services according to the religion factors? That as like you already explained that you are a priest of a Buddhism, so you are really easy to serve your society in your place. And what about Indonesian? What is your advices for us to prepare our units to be more educated in online services, especially in terms of religion form? That we know that Indonesian has 6 religions officially lives together in Indonesia. So how do you see that, and what is your opinion and advices for handling the religions unit form for online services in medical aspect? How do you see, sir? How do you see that issue, and how do you give the advices for us in terms of religion form, as like in your country, in Japan? Okay, that's all. Thank you.
Okay, thank you. I think the many Indonesian are Muslim, and you go to mosque
Yes.
so often, and you pray for Allah 5 times per day. So Muslim is so religious, but we Japanese are not so religious, and we seldom go to temple or shrine. Maybe some family member died, we go to temple, but many Japanese go to temple only twice, or maybe once or twice per year. So so we don't have a habit to go to the temple or shrine. So it is more applicable to the online temple or online shrine, because we seldom go to temple. So online temple is welcomed by the Japanese. But in Indonesia, going to mosque is very important, I think. So the online, how to say in English, online temple, online mosque is not good for Muslim in Indonesia. Is it right?
Yes.
I don't know sure. But so I think, but in the airplane, there is where is I don't know how the land of the, how to say, I don't know, I forgot.
Muslim tayammum, you mean?
No, the place of the Allah. I forgot. Okay, I forgot the name of the place. But I think for the Muslim, going to mosque is very important. So I don't think they accept online mosque. How about?
Yes, true.
How about Andy?
Mr. Andy.
Andy Stanto-san.
Andy, still there? Andy, still joining?
No, maybe.
I'm here, sir. I'm here, sir.
Okay.
I'm here, sir.
How about acceptance of online mosque?
I think it's not acceptable, sir. I mean that my question is, how do we prepare the officers or the person who is ready for serving the people, especially in Indonesia, as we know that Indonesian people are very complex with the religion. We have 6 religions here. There is Islam, Christian, Catholic, and also Hinduism, Konghucu, and another religion. So my question is, how do we prepare the officer or the person who's able to serve through the online service units, as you present before, like for example, like Buddhist priests who serve the Buddhist people. But in Indonesia, we have 6 religions already, so it's very hard for us to prepare the person who is ready for serving. I mean, so thank you very much for your explanation according to the Islam perspective. But what about the other religions, sir? How do you see that, sir?
In Japan, there is how to say, government has a department of the religion, and because temple and shrine, they don't have to pay taxes. They don't have to pay taxes. So the government management, the government manage the temple and shrine. So the Japanese government have the management, the responsibility to manage the shrine and temples. So the Japanese government has the department of the religion, and they control not only Buddhist, all religions, but in Japan mainly Buddhist, and only 5% is a Christian, and only less than 1% is Muslim or another religion. So, and now, as I explained the online temple is acceptable to Japanese, so the all information is available online website. And sometimes funeral party is done by online. Yeah, so the temple manage the grave. So the priest shows the grave, and the family member can see the praying for a grave. We can see online.
Yeah.
So the many religious activities are online now. So and they are managed by the government. Is it okay for you?
Okay. Okay, it's enough. Thank you, Mr. Andi Susanto, one of the best students from Health Polytechnic Office Kalimantan.
Okay,
The police officer in our town here. Ladies and gentlemen, because we have another session, I think we wish to thank Professor Nohiro Hashi
Thanks so much
for your interesting presentation, and the audience for attending and lively discussion. Thank you, and see you next another conference.
Okay, thank you.
Okay, thank you very much for Mr. Naori Hashi.
Thanks so much.
And the best result from Mrs. Dr. Endah to you, because she have any important activities today, so she had not joined in this meeting.
Thank you.
Thank you. Ladies and gentlemen, see you next session. Thank you.
Indonesia sejak dulu kaya akan nilai-nilai yang luhur dan mulia. Kerjasama adalah salah satunya. Sebuah prinsip dalam bekerja demi meraih hasil yang bisa dinikmati bersama. Di dalamnya terkandung nilai-nilai kesetaraan, kejujuran, saling menghargai, dan percaya untuk maju bersama. Untuk itulah, kami hadir membawa nilai-nilai yang sama. Sinergikan 3 bank syariah besar dan bertransformasi menjadi bank syariah yang inovatif, modern, dan memiliki visi global, bekerja sama dengan seluruh umat demi meraih berkah bagi seluruh alam semesta. Karena kami percaya, inilah nilai-nilai Indonesia demi memajukan ekonomi umat. Bank Syariah Indonesia.
Okay. Ladies and gentlemen, we will going to the second step and second session. And our prominent speaker, Mr. Dr. Muhammad Afzal Mahmud from School of Public Health in the University of Adelaide, Australia. Assalamualaikum, Dr. Muhammad Afzal Mahmud. You are there?
Waalaikumsalam, selamat hari ini.
Alhamdulillah. First of all, thank you very much for your join in this important meeting. And I apologize about the delay of this conference because I need trouble in technical.
No, that's fine. All good.
I'm very glad to see you again because several years ago, you have attending in Samarinda as a speaker in governor office and very best presentation can make Kalimantan Timur is Kalimantan people raise the good developmental for health service. Before going to the presentation, I just want to remind you we have 45 minutes 30 minutes for presentation and 15 minutes for discussion. And I'm very pleased to introduce background of Dr. Muhammad Afzal Mahmud. For educational background, beginning in 1985, MBBS quite exam medical college Bahawalpur, Pakistan, until philosophy of doctor in 2000 from the University of Adelaide, Australia. But one thing, very important thing must be discussed is graduate certification, health clinical education. Maybe this is very important if you can explain to us about this program. Because you PhD in 2000, and 2015 you get graduate certification for health clinical education. And the current position, Dr. Afzal Mahmud, senior lecturer and postgraduate coordinator, School of Public Health, University of Adelaide, Australia, and very glad as a young professor in Universitas Airlangga, Surabaya. And one thing, it's just for you to know, in Kalimantan Timur people, he is the governor's honorary advisor to Provincial Health Department is Kalimantan, Indonesia. Ladies and gentlemen, may I now invite Dr. Muhammad Afzal Mahmud to give the presentation. 30 minutes, it's yours, please.
Is it my turn? Hello?
Yes, please.
Yes. Thank you very much, Pa, for a very kind introduction, and I'm honored to be invited to this excellent, and I have been listening to the professor from Japan, a very excellent presentation on how to cater to the needs of different religious population groups. So excellent, and I see that there are about 400 people attending, so thank you for inviting me, and congratulations for a very successful seminar you are hosting right now.
Thank you.
I will try to keep it to as short as possible, maybe 30 minutes.
Yes.
There's a lot of work which we have done in Indonesia over the last 15 years. So my friendship with Indonesia started in 1998 when I started working a little bit with Trisakti in Jakarta and UI, University of Indonesia. Then it was about public health, but then I moved to mainly maternal health, and since 2008 we have done a lot of work in East Kalimantan, and for the last 3 or 4 years in East Java, Jatim as well. So Kaltim and Jatim are like home to me. This COVID has put a break. Otherwise, I used to come to Kaltim around 4-5 times a year.
Yeah.
So in a way, you can call me saya orang asli dari Kaltim, dan Arik Surabaya. So my task is to share my thoughts, and could somebody let me know that you are hearing me nice and clear?
Clear.
Do you hear me fine?
Fine, fine.
Hello? Oh, okay, yes, that's good. Thank you, Arifin Hidayat. He informed me that yes, my voice is clear over there. And I believe there is no need for translation Bahasa Indonesia. So my apologies, my Bahasa is not very good, so I will talk in English language.
Okay.
So my task is to share some thoughts on the role of midwives and what midwives can do. So I'll share my slides. There are about 31, but I will see how I can go quickly. I will not go into the detail of maternal mortality ratios, how many women are delivering in one or the other district. So today, my talk is not about the numbers. It's about the concepts. Why not number? Because you are all very well familiar with the maternal health situation in Indonesia, in Kaltim and in Jatim. And if not, this information is easily available at DEPCAS and DINCAS websites, and you could find that what's the situation. Unfortunately, COVID has caused the situation to go from worst to worst. So from bad to worse. For example, last year, or for the 5-6 year in a row in Jatim, we had about 520 deaths. And to my best knowledge, my friends from Arlanga informed me that the deaths in COVID year last year has increased, or this year has increased to double the number. Similarly, Kutai Kartanegara, where I work, the situation has gone from bad to worse. We had been able to decrease the mortality in 5 years, but it has gone back to the situation where it was in 2015 or 2013. So, but pray to God and hoping that next year the COVID impact will go away. But still, even after that, we still have a lot to do to improve the maternal health in Indonesia. So why I have shown you the bridges from Samarinda, from Madura Bridge and Kutai Kartanegara Bridge, because I believe that coordinated care, the links between primary care and hospital, between DINCAS and Rumah Sakit, between Puskesmas and Bidan Swasta, those links, those bridges are very important in order to provide comprehensive and integrated care. Unfortunately, in many places, those bridges are not strong or are broken, and women fall through the crack. And I will explain that in a minute. So there are many people to thank in both Jatim, Kaltim, and Java, who have helped me learn about Indonesia. I'm a student still, I'm learning. but we have some good research done in the last 15, 14 years, and my thoughts are based on those research conducted in many districts in Kaltim and Jatim in collaboration with Universitas Airlangga, Tinkas Provinsi, and University of Adelaide and Flinders University. So I go straight to the root, and that is that in Indonesia now poor pregnancy outcomes are mostly due to suboptimal quality of care with inadequate access as a lesser factor. When I say this statement, please note that I have a qualification to make. This suboptimal quality of care mostly influence women who attend class 3 in rumah sakit and in puskesmas. So hence social determinants of health, poverty, and those factors are still playing a lot of role. But within that sector, within that poor population groups in Indonesia, where most of the poor outcomes are, those poor outcomes are due to not that women do not have ANCHE or PNC, but because the quality of those ANCHE and intrapartum care and postpartum care is suboptimal, tidak optimal. We have conducted research in Samarinda and Balikpapan about antenatal care quality. We have looked at pathways of women where they go in Bontang to Dukun, to Bidan Swasta, Puskesmas, Ponet, Rumah Sakit, Dr. Umum Swasta. So that was done in Bontang. We did some work on who uses hospital and who uses primary care in Kutai Barat, and then a lot of research in Kutai Kartanegara, and then some research with Sutomo Hospital in Surabaya. So, but I'm not, today we do not have time to go into each detail. I will just summarize the finding. So this is one of the work which you may read, which is easily available. This was done in Kutai Kartanegara, and we found out what are the root causes, why maternal mortality is very high, and we found that the factors are in individual workers and at the organization level. There's another major work which we did in Jatim, in Sutomo and other hospital, and that was published last year, and that also pointed to some important factors like delays and poor communication and suboptimal referral and difficulties in transferring the patient from primary care from Bidan to Rumah Sakit. In Kutai Barat, we found out that the link between primary care, because primary care puskesmas are far away, 6 or 7 from the center where the hospital is, and it becomes difficult for women from the far away parts of the district to reach the hospital. In Bontang, we found out that women use, and this is the story everywhere, the women use a lot of different kind of providers, Bidan Swasta, Puskesmas, Dr. Umum Swasta, Dukun Hospital at various times during their pregnancy. Now, why all this is important? Because if a Bidan, a midwife, knows what is the story in terms of pathways, what is the story in terms of link between Puskesmas and hospital as in Kutai Barat, and what are the root causes, then that Bidan is well aware of the situation, and that Bidan can then act accordingly for her patient. So I say here, and that is one of the take-home message, that quality of care is not only how good one is in treating malaria or dengue or obstructed liver. Quality of care can happen only if the provider understand on one hand the social determinants, what are the socio-cultural issues impacting the woman, and on the other hand, she, healthcare provider, Bidan, is well aware of what are the limits and strength of my health system. So any Bidan, Amarinta atau swasta, unless she knows what are the social determinants and unless she knows what are the system issue, she cannot be an effective and optimal quality care provider. Even if she knows absolutely in a good way how to treat eclampsia or how to treat Pardanahan at her level, because one needs to know both sides of the story. So that's why this research was useful. So some other research, in addition to what we have done in the last 10 years, there's a many research done, very good research done in Indonesia by Indonesian friends and colleagues, like Adnani has pointed to that many midwives are not having hands-on clinical experience. And I have also noted in Kutai, in Kaltim, in Jatim, that many midwives are put on tasks where they are not using their training which they get into the Bidan Academy. They are not used, hence they lose their skill. So if a Bidan does not deliver a baby, if a Bidan does not provide antenatal care, in my view, only 1 year and she will lose her knowledge. So that hands-on clinical experience, Adnani is very right in my view. Similarly, Limato and her friends, they say that the leadership, that Puskesmas, Kapala Puskesmas and Bidan coordinator has to look for quality improvement process, get the Puskesmas accredited. If those things are happening at the Puskesmas level, then the Bidan at that Puskesmas will be able to pursue quality care, because that team of Kapala Puskesmas, Bidan coordinator and Bidan, then they will become enthusiastic and work in collaboration with the hospital. So a culture of quality is needed. Not only the technical and medical knowledge, but also the culture of quality, where quality is considered important. Then Indriani published, I think it was not 2008, maybe it's 2018, challenges faced by rural midwife, that many rural midwife in Puskesmas and private capacity, they find it difficult to keep their knowledge updated. They find it difficult to communicate with the OBGYN in hospitals or with the Bidans at the emergency department in hospital. There is an issue of authority as well, that sometimes mixed messages come and they feel not part of the team and they feel low, disempowered. Their workload sometimes is very high, there is one or two, so there is a poor distribution of midwives. Some Puskesmas have many, and some Puskesmas in rural area have very few. And that distortion of the workload I have seen personally in many places. Some are overstaffed and some are understaffed, and there are some political issues which does not help Bidan to have in a balanced way to be distributed across the state, district. So what is going good? Good in Indonesia is that almost everyone, even in very remote area, rural areas, are having antenatal care by skilled midwives, 99.7%. So between 90 and 95%, generally speaking, in many places, except in faraway places like maybe Malino and others, I do not know. Maybe in those places it might be less than that, but generally speaking, it's very good. So for Anche, more than 90%. Even in many places, many women are now getting Anche by obstetrician. And many women are now being delivered at hospital. In some places in Java, in big cities, even 40-50% are delivering. And then there are many who get the C-section if needed. In rural areas, 17, in urban area 23. So this is our research. But that is what is positive. But what is not optimal? And that is where midwife need to focus. I categorize these into 4 on the basis of my research and my team's research. One very important is inadequate management of cultural, social, and economic factor. And I will give example later on, but for example, just briefly sharing with you that going to the hospital could not, or not going, not taking up the referral, maybe that the culture in the village and culture in the hospital is very different. And the women may be afraid of going into an alien place where there are people in the white coats, there are corridors where family cannot sit with the patient, or family does not have a place to live or cook, and they have to sit in the corridors of the hospital, and the women feel that their swami or their family will become troubled if she has to go to the hospital. So that could be a socio-cultural issue. Economic, yes, we have Bidan have access to insurance for their clients, but many times that insurance is not enough. Transport may cost them. Accommodation in city when they go to hospital may cost money. Transport may cost money. Additional medicine from outside the hospital may cost money. Food for the family members. So there are many economic factors, and a Bidan who's referring the patient needs to look at the socio-cultural aspect of the women, and what it will require. It will require a good discussion, and the time we do not have some time. So that's one, the green one. In the blue one, and I think that's a central point, inadequate communication. And our research in Kutai Kartanagara and then in other places also showed that the effective time, 20 minutes, 30 minutes is needed for the first consultation, first armchair, maybe more than that, to take a good, long, detailed history with the patient. That is not happening. So Bidan needs to focus on that. Then the communication between Bidan and hospital Bidan and Bidan at the Igire, that is very poor. The reason is that Dinas ke Sehtan and Ruma Sakat are not talking in a very congenial way. So they are working in silos. So that effect of lack of communication between Dinkas and Ruma Sakat impact on the Bidan. So how they can deal with that issue? I'll come to the solutions. Another is the inadequate risk communication and management. I have found, and our team has found, that the risk identification is becoming good in Indonesia. For example, identifying blood pressure, identifying other risks such as maybe suffering from diabetes or some other concomitant illnesses. But after the risk is identified, risk is not very well communicated to the women, that what will happen to you. Similarly, the risk is not managed, because risk management requires facilitated referral. Risk management requires obgyn and midwife working together hand in hand for the rest of the pregnancy, and that is where the problem is. And then non-facilitated referral. Please go to the hospital is not a referral, that is a prescription. A referral is where we facilitate, we make arrangement for the transport, we make sure that she has the money, we make sure that she knows where she is going, we make sure that the hospital which is to receive that or obgyn to receive that, he or she knows that a woman is coming. So that lack of facilitation is based on this blue one. Poor communication cause poor referral. Then in Java, we noted that many times when the patient is transferred from the post-case, there is not sufficient information. How much blood is lost? If the hospital is not given information on telephone that I have a woman who's losing blood at this rate, and by the time it reaches you, and she would have lost about 3 or 4 liters of blood, the hospital will not be ready to receive the woman and will not be ready with the blood in their hands at the emergency room. And then there's another issue of pyramidal referral. Pyramidal referral again is an important issue. We sometimes need to refer from post-case. BIDAN needs to refer from level E, then to level C, then to level A. But sometimes it causes problem, because sometimes it is absolutely important that the BIDAN send the patient to the right place. And I have seen many women die because they were sent to the incorrect hospital where services was not available. So this triangle, whichever way you put, up, down, sideways, in my view, these are the categories of the problem which BIDAN are facing. And we need to help those BIDAN deal with this complex problem. Over here, I mentioned in the red area, risk management. Have a look at this. This is the research we did in Kutai Kartanagara. And even for the women who had more than 2 risks, 3, 4, multiple risks in pregnancy, such as past C-section, umur, medical condition, hypertension, miscarriage, the past, multi-para women, if they had more than 2 or 3 or 4, still up to 40% women did not deliver at the hospital, and up to 25% did not have a single visit by object. This is a very high risk area. So BIDAN needed to refer these patients and then make that refer facilitated. Make sure by follow-up that these women are delivering in the hospital. The other areas which we found out, failure and delays in emergency, and quite often it happens because of the lack of communication from Puskismas to emergency department, that what patient is suffering from and what is needed when the woman reaches the emergency department. So she reaches there, and then there is a 1 hour delay because people then start assessing, people do not know that she will be arriving. Delay in procedure happen again because of that lack of communication from primary care to the tertiary care, and sharing information between primary. So these are linked with each other, these red bars. Other issues where BIDANs could play a role is the knowledge and skill lacking. This happens because many BIDAN are put to the tasks, for example, only vaccinasi, only chatatan and writing in the registers, or only doing some administration task. Those BIDAN lose their skills very rapidly. And if they are trained in hotels, or they are trained in Dinaske Sehatan training room, not in Puskismas, not in Rumah Sakit. So refresher training for BIDAN must be hands-on under the supervision, and they should be linked with mentors. This is one of the major reasons we found. Poor communication already mentioned, and failure to follow the best practice. Quite often protocol and standard operating procedures are not available, not displayed on the walls of the room where BIDAN is providing unchecked. So they tend to forget. They do not have a checklist in front of them always. And that checklist is not followed often, and then they fail to follow the standard operating procedure. So we found this in both Jatim and in Kaltip for research. Pyramidal referral, I mentioned to you that a BIDAN sitting here in the Puskismas may send the patient to be somewhere level D, and then it goes to level C, and then go to level B or level A, because this Bidan sitting here does not know what is the capacity of this hospital, whether they can do the C-section or not, do they have the blood bank or not. So for a Bidan here, it is absolutely important to categorize the risk, that this woman has a risk which cannot be managed at level D. For this to happen, Bidan coordinator, Kapala Puskismas, Bidan Swasta, Bidan Pamarinta must know their system. What can be done in Parikasid, what can be done in Kanujoso, what can be done in Vahabsaran. So where we should send them. So this is one of the case study where a woman was sent to incorrect place and she died because she was bleeding, but she has to wait, had to be transferred from one place to another place, and that caused a delay, and unfortunately she died due to those pyramid causing delay. So this is an important slide. Please have a look. How many minutes I have? More minutes, please. Dear organizers.
Yes, please, just going on.
Could you please tell me how many more minutes? How I'm doing with the time?
About 5 minutes more.
Okay, I'll continue.
Okay. 5 minutes.
So as I was saying, this is an important slide. What it says is that there are 3 categories of problem. The problem could be cultural, problem could be managerial, and problem could be technical. Technical mean medical. So if the problem is a cultural problem, we cannot manage that problem with a medical skill. For example, if woman is reluctant to take up a referral and does not want to go because she thinks that she has little money, and that money she will use on the road for the food in city or for accommodation for Swami, etc. Or she may be worried about the hospital, that hospital, I do not know anyone over there. Yes, I can speak Bhasa and they can speak Bhasa, but I don't know. It's an alien place. Who I will talk to if I need something over there? So people feel a little bit difficulty. So can this be managed by having a better skilled midwife who knows medical or midwifery knowledge? No. It requires knowledge of the culture of the woman. It requires knowledge of her socioeconomic situation, and it requires good communication skill and good facilitation to make sure that the women is supported. If there is an issue which is a managerial issue, for example, poor referral link with the hospital, can Bidan deal with that managerial problem through midwifery skills? No. Can we deal with that managerial problem through cultural solutions? No. Because it's a managerial problem. It's a lack of link between Dinaske Setan and Rumah Sakit, and lack of link between Puskismas, Dan, Rumah Sakit. For that, solution needs to be a managerial solution. Kepala Puskismas, Bidan coordinator need to have established relationship with the area hospital. They need to know the people over there, negotiate some links, and then the Bidan at that Puskismas would be able to easily transfer patients to that hospital. If the challenge or problem is technical or medical, like lack of knowledge, how to manage the blood pressure, then of course we need the medical and midwifery training. So these 2 slides this slide where I summarize and categorize the problem in way of what problems are, and here I again summarize them from a technical, managerial and cultural problem. So, taking the example, for example, if there is a culture within the hospital where bidan or cannot wake up a sleeping objin because she's afraid that the objin will be angry, that's a cultural issue, that's a hierarchy issue. We need to make them a team. We need to make sure that there is a some sort of a taman friendship relationship where she's not afraid of calling at 2 a.m. in the morning and wake him up. Everything will be all right as many other women with similar issues. So sometimes there's a culture that, inshallah, everything will be all right because many women suffer from this problem. This woman will also be all right. Here, we need to make sure that this kind of a cultural impression of a technical problem needs to be dealt with. So midwife needs to be trained that every woman is at risk, every woman. Doesn't matter if many other women survive, this woman can die. So we need to treat every woman as if she will develop problem, and at that time one needs to act. For example, this is a managerial problem, transferring the patient to hospital without adequate information, and it's a technical as well. Some bidan did not know how to calculate how much blood is lost during hemorrhage or darahan. There is a formula, or there is a, and you need to know what was the starting hemoglobin. So if you do not calculate properly, technically, because you do not have skill for that, then you will send a patient to the hospital without the information, and hospital will not be ready with 6 liter of, or 6 pint of blood, which is needed. So they will have only 1 pint, and women will not have. Then sometimes we keep on saying, oh, let's try this medicine, it may work. Or, medicine, obat 1, obat 2, obat 3, obat 4, without looking at the clinical protocol and asking some senior people, that because we do not have the knowledge, this is a technical issue. Then sometimes there's a managerial issue. Bidan are not looking at the patient in hospital, OPD, and they are sending everyone to Obgyn. Let Obgyn see that, because this is a policy. But in that case, Obgyn may become overcrowded. He may miss the diagnosis because he's overcrowded, and midwives will lose the skill. This is a triage issue. And then sometimes there's another cultural factor. If I ask for help, then maybe Obgyn or my midwife coordinator will say, I'm not well trained. So many bidan do not ask. A good clinical care provider is one who knows her limitation. But the problem is that many times we do not ask because we are afraid that if I ask, other one will say, you do not know.
Excuse me, sir. Time is up.
How many minutes? Sorry?
Time is up, sir.
Time is up. Okay. Can you give me 5 minutes only?
Okay. Yes, please.
Yeah. Thank you. I will quickly do this. So if we understand this whole cultural, managerial, technical issue which we need to learn, and that triangle problem, we focus on those things, bidan's quality will improve. Let me go to the next slide. So I will very quickly pass from these slides, and will say that we need a coordinated primary secondary care. I have already said that. The link. Bidan's training only will not help. We need to link the Puskes pass with Ruma Sakar. We make the friendship. We need to engage Bidan into improving their communication and make sure that they are using Bukukaya, that Obgyn are writing in that Bukukaya, and then Bukukaya goes back to the Bidan. and Bidan then look into that. We need to look at the cultural factors, as I mentioned before on the slide. So we need to change the culture within the organization. I'm not talking about the Indonesian culture. Indonesian culture is a beautiful culture. Okay? I'm talking about the organization culture, how things are happening. And we need to make sure that the training is action oriented. It's not in a room or in a hotel all the time. It needs to be on the bedside. It needs to be like in Samboja, we are doing what we call a duck and duckling. For my friend Dr. Prem goes to the Puskesmas and train Bidan over there. And sometimes Bidan goes from Puskesmas to Samboja Hospital and get trained over there. That's the action-oriented, bedside-based training. So those kind of training will change the ineffective Anche to more effective Anche with the use of Buku Kaya, with comprehensiveness, with good referral, and good use of standard operating procedures. Link with hospital, I already mentioned. This is absolutely important. Medicine and midwifery and nursing, they are professions where a single provider is always a problem provider. We are a team business. Health business is a team business. We need to have friends across the system. And I mentioned in the problems that risk identification is happening, but risk management is poor. Risk management will happen if the referrals are facilitated, if follow-ups are happening, and if we use certain protocol like the one I'm showing. It's called modified early warning system, where according to the standard operating procedure, you increase the level of oh, this person is at higher risk. Now Bidan should not see, Obgyn should see her. So we can use certain protocol for risk management. Communication, we again did a study and we showed that those women who had higher risk, but their Bidan was more communicative, more linked, those women had a better chance of survival and better chance of good outcome compared to those whose Bidan was less communicative and less linked. So I finish here, and I hope that I have been able to get the message across, at least 3 messages. Number one, we need to focus on the system and not only on the individual Bidan. Number 2, we need to look at the categories of problem at a Puskesmas which are affecting Bidan, and then we provide solution. If it's a cultural challenge, provide a cultural solution. If it's a managerial problem, provide a managerial solution. And if it's a technical, medical midwifery problem, then train the people accordingly. So that's me, and I'm ready for your question.
Thank you for your presentation, Mr. Afzal Mahmoud, for the interesting impression. Before going to the discussion, as I can see, there are several main issues that I can say this. The first, the link between Dinas Kesehatan, Rumah Sakit, dan private midwives was very important, like the bridge. So if there was crack, it make a bad impact. Cause to poor pregnancy outcomes, mostly due to subnormal quality of care, with inadequate access to care as a lesser factor. Full link between primary care in rural or remote areas and hospital care. Quality of care meaning that the midwives keep to the look and meaning the important factors of services the women. Challenge as faced by rural midwives, skill and knowledge update, communication, authority, workload, poor facility, and infrastructure. And the second one, not optimally things, paramedical referrals, inadequate management as facilitate cultural, social, and economic factors, inadequate communication, unintegrated and non-comprehensive ANC, non-facilitated referral, and inadequate risk communication and management. And then the other factors that midwife can, supervisor could change relatively easily: failure, delay in emergency response, delay in procedure, knowledge and skill lacking, poor communicator, and failure to follow best practice. And the solution: technical managerial, medical knowledge and skill training, as just you said just now, managerial, dinas kesehatan, rumah sakit, negotiation, institutional, and LPA link, and the last, cultural social, facilitate subsidized care, inform and reassure about culture of care and hospital. Ladies and gentlemen, we're going to discuss. We have 15 minutes, and perhaps there are any questions. Please address your question, whether in the live chat or directly. Before asking your question, please state your name and your institution clearly. Please.
Thank you very much. Hello, Dr. Mahmud. My name is Triana. I am from Permata Husada Midwifery Academy in Samarinda, East Kalimantan. Speaking the truth, I'm very amazing, very amazed from your presentation, because you did the research in East Kalimantan, in my province, and your data is very, very important for us, even if I'm not a policy maker, but I think it's a good idea about doing your research data to improve our curriculum maybe, because we are also part of the healthcare education. And I want to know about, I believe that you do the research along the country beside East Kalimantan. Maybe you know that there are similar province or similar country that also has similar problem, similar issue with Samarinda or East Kalimantan, such as geographic conditions. That's because the geographic condition also a part of the problem, that communications, maybe about the patients from the rural area to the better healthcare provider. It's very common problem in East Kalimantan. When I look at your presentation, I don't even blink my eyes, because I'm very surprised about your data. It's very important for us. Thank you.
So thank you. Thank you very much. May I reflect on this?
Yes.
Yeah, okay. Thank you very much, Ariana. This is, and I'm thankful for your kind words. As I said, I feel I'm a Kalimantan person because I have drank Mahakam river water, so I keep coming back. So, and the other thing which you mentioned, the local research, I encourage you research is not a very difficult as promoted by these university people. Everyone does some research. When we go and buy our groceries, we find out where it is the cheap and cost effective, where the material is good. So everyone is a researcher, every human being. So in order to improve your own post-Christmas, improve your own academy, you need to do some local search. What is happening? What is the situation? You need to ask yourself, Dr. Afzal came to this conference and give us 10 different challenges. What is my challenge in my post-Christmas? Say Kahala in Kutai, or maybe post-Christmas in Balikpapan or somewhere. So if you are the manager there, you need to do some local to find out what is my priority. So thank you very much, Rihanna, for mentioning local research. And this allow me to give you the idea that please do not be afraid of research. You can do a little bit situation assessment in your place, and you must do that. And the other thing you mentioned, whether the situation is same or different in different places, of course, there are certain differences. For example, across the Lake Kahala, in rural area, in jungle area, of course, there is a different issue. There are lack of facilities, there's lack of transport, people have to come by boat or katintin or something like that. So when you are a bidan in those areas, Raba area, or behind the mountain, you need to keep those risks in your register. My women are 3 hours from the hospital. If she develop Pardarahan, then how much blood she will lose? So my patient, my women, is different from the one who live in Kota Bangun, because in Kota Bangun is 2 hours, but my women live in a jungle, so it's another 2 hours. So all these things are part of your quality. So thank you for mentioning geographically. Yes, it's a very important issue, geography. Bidan needs to consider that as part of the treatment. So thank you.
Another question, Professor? One more question.
Mr. Nahru Nugroho has raised his hand.
Hello, Mr. Afzal Mahmud. My name is Nur Hasana from Health Institute of Mutiara Makam, Samarinda. According to your presentation about solution must be matched with problem, there are show that any problem like technical, managerial, and cultural, social problems. And my question is, if we can make a priority of the problem, which problem that can we take as a priority to improving our quality of healthcare? Thank you.
Thank you very much, Nur Hosana. Very, very good question, and thanks for asking. I think if you can focus on 2 things. One is the training somehow needs to be improved and make it action-oriented training. Use the training to link Bidan with Obgyn. Make them friends. So it will do 2 purpose. So like killing 2 birds with 1 stone. It will not only improve the knowledge and skill, but it also develop that friendship which is needed for integrated care. That's one. Action-oriented, hospital-based, mentorship-based training, and the other is communication. Please, please, please focus on that. The communication between Bidan and Bumil. That needs to be absolutely based in Indonesian culture. Indonesian culture is a beautiful culture where people respect the fellow human being, where people talk politely, where people give each other time. Like in Australia, if I ask someone, people are very busy. Okay? Over there, people are, if you ask someone, they will help you standing with you for half an hour. So stand with your Bumel for 15 minutes, 10 minutes. Spend time. Communicate the risk. Use the communication to link up with the bidan in the area. Link up with object. Use written communication as well in Buku Kaya. In the referral note. So communication is the key. So good action-based training, refresher training, action-based, and number 2, the communication. If you ask me, I will start from here, and then other things will inshallah help.
Thank you for the answer. Maybe any question? One again? Enough? Well,
there are 2 or 3 people on internet. Miss Anissa Wulan and Nahru Nugroho. They have raised their hands.
Okay, just one more. Before ending the session.
Maybe
Okay, Assalamualaikum. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay. Halo.
Halo, lanjut.
Go ahead, please. Go ahead.
Okay. Thank you very much. My name is Nehru Nugroho from Poltekkes Kemenkes Bengkulu.
Oh yeah, good.
Good. Okay. I'm very interested for the explanation for this information for Professor. I want to know about in the collaboration with government. In the government, can the program with safety village desa siaga. I want to relevation program with the safety village in the management. I want to the relevation about the collaboration with government. Thank you.
Yep. Thank you very much, Mr. Nahru Nugroho. Thank you. Good question. Good question. I should have mentioned there are cadre and there are Desa Siaga program. These are very important initiative, but unfortunately we have not utilized those 2 very good initiatives to the best of their potential. This all is about community participation and community empowerment, and we can address many cultural and socio-economic barriers by engaging with cadre and Desa Siaga appropriately. It's a long discussion how we do this, but I think we are not empowering them. We need to make and empower them. For example, I give you one example. I went to Kutai, one district. I went to Kampong, many. Okay.
Kampong.
I met with many cadre. I met with many Desa Siaga people. And when I asked, what is the name of Kepala Puskesmas? Simple question. They did not know the name of Kepala Puskesmas. Okay? When I asked them what is the telephone number of ambulance driver, they did not know that. It means that they did not have even the basic information which they can use to facilitate the transfer, to make a phone call, etc. So a cadre who does not even have the name and number of Kepala Puskesmas is a disempowered cadre. We need to change that. We need to make them powerful, and we need to engage them at that level. I hope it helps, Nehru.
Yeah.
To power them.
Okay. Thank you for your explanation. Thank you.
Well, thank you very much for Dr. Afzal Mahmood. Okay, ladies and gentlemen, if there are no more questions, we shall end this discussion. And once again, I wish to thank to Dr. Muhammad Afzal Mahmood from Australia for interesting presentation and the audience for attending and lively discussion.
Very good. Thank you very much, Pa.
See you next another conference. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Selanjutnya kami serahkan kepada moderator, please, kepada MC, please.
Hello, Mr. Edi Sukamto. Okay, thank you very much for Mr. Edi Sukamto as a moderator. I think Mr. Edi Sukamto was very enjoy the discussion with the two interesting presentation with two incredible presenters. But it's too bad the time was separated. But it's okay. We still have two incredible presentation. So next, who is that, Miss Dita?
Okay, now we move on to the third and fourth section that will be led by Mr. Isman Shah, Master of Nursing, with the main speaker is Mrs. Barakatun Nisa Muhammad Yusuf, PhD from Malaysia, and Mrs. Dr. Dwi Prihatin Era from Indonesia. Okay, please welcome our moderator, Mr. Isman Shah, Master of Nursing.
Okay, thank you, Master of Ceremony, for me. Now I wanna lead the third and the fourth presenter or speaker today. And for the first time, I want to check Mrs. Barakatun. Assalamualaikum, Mrs. Barakatun, are you there?
Waalaikumsalam warahmatullahi wabarakatuh. Apa kabar Bapak?
Alhamdulillah, baik sekali.
Baik saja ya.
Yeah, because we live in the same island, Kalimantan. Okay. Okay, good. I think we can combine between English and Bahasa. Because,
right.
Okay, good day. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, for this session, please welcome Mrs. Barakatun Nisa Muhammad Yusuf, PhD, from Faculty of Medicine and Health Science, University Putra, Malaysia. I'm very pleased to introduce her. Her name is Barakatun Nisa binti Muhammad Yusuf from Department of Nursing and Dietetic Faculty of Medicine and Health Science, University Putra, Malaysia. Current position, Associate Professor, and field of specialization, clinical nutrition and dietetic, diabetes, obesity and metabolism, glycemic index, nutrition education and counseling. And her education background, she received her bachelor science degree at University Kebangsaan Malaysia on 2002, area of hospitalization, dietetic, and taken her PhD on 2009 at the same university and the same area in specialization. scientific experience and specialization as a member of Johnson Diabetes Center, Harvard Medical School affiliated position, research fellow, start from 1st October 2015 until 30 September 2016, expertise in diabetes clinical nutrition. Mrs. Barakatun, I inform you that we have 45 minutes, 30 minutes for presentation and 15 minutes for discussion.
Right.
Okay. You can hear my sound clearly?
Yeah, loud and clear.
Okay, thank you. Well, ladies and gentlemen, may I now invite Mrs. Barakatun Nisa Muhammad Yusuf, PhD, to give the presentation by topic Virtual Interprofessional Education in Managing Obesity for Healthcare Professional Students. 30 minutes is yours, Mrs. Barakatun.
Terima kasih. Terima kasih Bapak. Ya, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
First of all, I would like to thank the Ibu Indah who has been inviting me to be here. Ya, and juga Bapak sebagai pengerusi majlis who has introduced me very well. Thank you for your kind introduction.
You're welcome.
Alright, so let me share the topic. It's about the virtual interprofessional education. And I'm choosing obesity because that is my area of practice, as well as the teaching area, and perhaps familiarized by most of the healthcare profession students here, nursing, nutrition, where we've seen the increasing number of obese individuals. Right, let's start. I would like to invite all student participants here to join me at slido.com, hashtag 539977. So you can join me so that we can have two-way interaction throughout the presentation. Right. Okay. So I believe you have done it. Okay. So let's start with the first question that I would like to know. Hold on, my screen is off. Okay.
Okay, next.
Before we start, in one word, right, I'm not sure why. Let me start again.
Okay.
Okay, hold on. Okay. Right. It's already Zoom fatigue, I guess. Okay, let me try it again.
Okay, let's try.
Okay. Right. So share it again. Okay. Okay, in one word, can you describe your experience using virtual reality, perhaps? I can't remember the question.
Yes, waiting
Can
for
you see
your
my slide?
Yeah. No, not yet.
Boleh, ya?
Yeah.
Okay, so you join me at Slido. Right, in one word, how would you describe your experience in using virtual technology, perhaps? Pandangan bapa-bapa, ibu-ibu, para pelajar, adik-adik berkaitan dengan penggunaan virtual reality technology. So I received, I'm sure the young one are very familiarized with the VR. So only 2 students, only 2 participants. We have 300, so at least maybe 50 of them, 50 of you. Yeah. Right. Okay, any others? Okay, so it's okay. You can join me later. So in general, what is virtual reality? Just to recap, virtual reality is a simulated experience that can be similar to or completely different from a real world. Yeah. So I would like to highlight the word simulated here. So if you use this pyramid of teaching that we've familiarized with, yeah, we know that 75% knowledge will be absorbed well when the student are given, yeah, a simulated or learning by doing, yeah, or practice by doing. So the role of simulation is very important, especially in teaching medical and health sciences. Okay, can you help me to identify what are the examples of virtual reality from your experience that you have embarked perhaps, or you have used in your class? Or you play game with virtual reality? Anyone? Video call, okay, cool. Any others would like to try? Zoom, okay, Zoom platform. Others? Neopod, I haven't heard about Neopod. VR game, we have a lot of VR game out there. Maybe you wanted to be more specific. Ya, namanya yang betul? Okay. So the one that anak-anak kita yang main di rumah, the games that they currently being using at home, if you realize, okay, it's okay. Then perhaps towards the end, you can also suggest to me later on. So basically, this is the content of my presentation. We will look into the IPE, interprofessional education, what it is and why it is important, especially in managing obesity. Yeah. And of course, we will zoom into the virtual education in IPE. And I'm using in this context, I'm using Second Life. Yeah, if you haven't heard, or maybe some of you have heard this before, then this is a fact. This is the platform that I use to develop the virtual interprofessional education. And of course, the way forward. So let's start with the IPE in managing obesity. Ladies and gentlemen, yeah, I'm sure that all of you have been seeing this graph many times, yeah, and we know Malaysia has the highest rate of obesity in Southeast Asia, yeah, as compared to Indonesia and other Southeast Asian countries. To be specific, 1 in 2 Malaysian adults are either overweight and obese. Yeah, so we have a big issue in managing obesity in our country. So when we look at into the factor or the cause of obesity, ya, perkara faktor-faktor penyebab kepada obesity, we understood that it is beyond diet. Yeah, although diet perhaps play an important role to contribute to obesity development, beside physical activity that divided into exercise and non-exercise activity like the usual work, there are also other factors that has contributed to the cause of obesity. And from this paper, they said that obesity system map, the causes are multifactorial. Yeah? As you can see here, you can see it's not only about food, consumption and production. There are also individual psychology, activity that we understood, environment. Yeah, people always give reason why they do not want to go for exercise. Yeah, and during the MCO, Movement Control Order, we realized, yeah, I have just read one paper that seeing a lot of patients with diabetes during the MCO period, they reduce their activities and they cannot control their food intake, which contribute to the future increased risk of obesity and poor glucose control. Besides other factors, there are also hormonal that include under biology. Yeah, like study have shown those who are obese, they are more insulin resistant. You understood that? As well as leptin resistant. So when they are leptin resistant, this is the one that cause them experiencing delay in satiety and increase in appetite. So we cannot blame them 100% because biology we can't control. It is what happened inside. And not to forget societal influence. Yeah. So how people perceive obesity as a disease is also important. If obesity is always correlated with cosmetic issues, then it doesn't work that way because individuals need to perceive obesity now is considered a disease that we have to treat. Yeah, right. And I would say that obesity is a complex based on the multifactorial causation just now that you have seen. Yeah, and studies have shown that when they use multidisciplinary team to treat obese patients, it's helped to improve the clinical efficacy. Yeah, this is from general practitioner perspective in China. So what do they found? They found that it's enhanced the weight loss success rate and it's also improved blood glucose, blood lipid, and adipokine levels. Yeah? And therefore, it should be part of the practice. Yeah? When we're managing obesity, it should require multidisciplinary team to ensure effective outcome. So who should be part of the team? Yeah. So in our clinic, for example, we do have metabolic obesity clinic every Tuesday, like today. Yeah, so I won't be able to go, and I'm requesting my other dietitian to come. Yeah. So we do have, of course, a bariatric surgeon because we are seeing obese individual with BMI more than 40. If there is a need for them to go for surgery, yeah, especially those who have failed with diet and exercise because we can't wait. Yeah, they come with multiple comorbidities. So we do have endocrinologists, physician, ENT consultant because majority of them is also present with sleep apnea. Yeah? Since we know that individual psychology is also contribute to obesity, we do have clinical psychologists here to help us in managing their behavior. Dietitian, nurses, also as part of the important team management in obesity clinic, and not to forget rehab physician because we understand for those who embark into a weight loss journey, they would require not only the dietary intake management and also physical activity management. And we can't just prescribe simple exercise to them because they also come with various comorbidities. And therefore, we call on the rehab physician to give them an appropriate exercise prescription. Right? So this is how the IPE looks like in the real scenario of my clinic, our clinic in UPM. Yeah? And from the literature, interprofessional education that all of you mungkin biasa dengar, selalu guna, refer to occasion when students from 2 or more profession learn together during all or part of their professional training. So we do have here in our work-based scenario, but it's quite challenging to bring students for us. Yeah, so therefore we create this, yeah, so that student will learn everyone role is important in managing obesity. Okay, and then this is the framework how interprofessional education, which is also being recognized by World Health Organization, is one of the important component, yeah, in managing complex diseases, which also include obesity. So there is a health net, and it is also considered as a future health workforce. Yeah? So therefore, in order to develop collaborative practice ready health workforce, we have to introduce IPE early in the curriculum. With this IPE curriculum, we can advise our students and encourage them to work collaboratively. It's not easy to work in a team, yeah? To compile and to include all of this under one clinic is not easy. The nurses play an important role to make sure all of us are come on time, seeing the list of patients. So nurse play an important role as I can say she is a clinic manager. That arranging all appointment, yeah, and all patients to be seen by whom. So nurse play an important role here. So it's like a collaborative practice that support future practice, and of course, study have shown that it will improve health outcome. Yeah, and if you look at into the top 10 skill of 2025 for the student especially, yeah, leadership and social influence is one of the skill. Yeah, work under categorization of working with people, which is important for the future needs of the graduate, right? Right. So therefore, we conducted, before the pandemic of COVID-19 back in 2019, we conducted the interprofessional education workshop involving nursing, medical student, as well as dietetic student. The three area healthcare professional program that usually embark in hospital setting, in our faculty. So we put them in the workshop. We mingle them around. In one group, they are include medic student, MD student, nursing student, and dietetic student. So you can see here the first graph to show the knowledge of managing obesity before the workshop. It's more focusing. Nampak dia lebih kepada tengah-tengah. Markahnya begitu. But at the end of the workshop, you can see the bell shape is more at the right side, where majority of them has improved their knowledge better. Their attitude towards IPE at the beginning of the workshop is quite low. It's out of 7, and at the end of the workshop, it's ranging from 6 to 7. So students enjoy the session, they understand their role, and at the end of the workshop, they are able to convey their experience, their main role. They don't really take other role, but they understand what are their roles in managing obesity. Okay, so you have seen this before, the pyramid of learning. So when we talk about IPE workshop, it's more on the discussion group, or when we bring them into the classroom or the lecture, is even worse. So without the discussion, the knowledge absorbed is only about 5 to 30%. But then with the discussion, is absorbed about 50%. But we always puzzle, how are we going to have the same thing in the context of real scenario in the clinic, to show them how to simulate all the knowledge that we provided in the classroom to the real base clinic. So this is the gap analysis that we found. What are the challenges to conduct the physical or face-to-face IPE? So we thought at that point of time, face-to-face IPE is not feasible. We have to have a dedicated workshop because it's not part of the current undergraduate curriculum. So we don't have one specific time for all the students in health sciences gather and learn the same thing together. We don't have that at this point of time because our curriculum are designed as separate individual program. So that's a challenge. Although we are staying in one roof. And IPE to a real world is not possible because in the clinical setting, when patients come, we have a conversation and our focus is more on the client. So without a prior exposure to the student, they might be quite blur what to do when they are in the clinic, especially during the busy clinic days. And of course, it's involved patient safety, patient privacy. When you're managing people with obesity, they are quite secretive, and their data, they don't want people to be in because there's a lot of issues to be discussed. Sometimes they are not comfortable when students or when other people other than professional are there. third, I think logistic concern. It's not easy to scheduling. Yeah, even my nurse manager is quite challenging to schedule all the help, all the expert, the team members to come to the clinic. She has to text, ask us, give a schedule, and make sure all of our patients come at the same time. Yeah. Being a student is also not easy to make sure that they can have IPE in their schedule. Logistic concern, gathering them at one time is not easy, especially when COVID come. There is no more face-to-face classroom where everything become online. Our clinic is also turned to become online. We give telecommunication, teleconsultation to the patient, where patient is at home, our student in the hostel, and we are alone in the clinic during the pandemic of COVID-19. And to me, COVID-19 is perhaps in education is blessing in disguise. It has accelerated, dia mempercepatkan digital education. I'm sure last time we do not know how to use Zoom. Now the younger child, even at 6 years old, at the kindergarten, is the one who are able to use Zoom even better than us. Right. So now let's move on to the virtual education. So virtual reality in IPE. This is the recent study by the pharmacy student where they look into in-person IPE versus virtual IPE. And they focus on professional communication. So what do they found? 90% of pharmacy students in the virtual group felt that they learned something new regarding therapeutic management versus only 84%. It is not statistically significant, but there are a tendency those who are staying in the virtual group have more confidence. Perhaps because they are not face-to-face, they can gain the confidence themselves. And this paper conclude that using a virtual modality for communication was not dangerous or detrimental to student attitude, because we know that we during the pandemic we miss communication, physical communication. And this paper, they're afraid that if they introduce virtual IPE, it will worsen student profession in communicate professionally. But this study does not find as such. In fact, we can say it is comparable or slightly better during the virtual professional communication. And this is a scoping review that recently published in March in one of the Nurse Education Today journal, where they found that the paper support the usability of virtual reality for IPE, and as a new teaching modality, the immersive virtual reality experience promote IPE collaboration and communication. And future advance in the use of this technology are expected. So there is a potential to use in health science education. So what we did, we look into the proposed solution. So we wanted to introduce IPE, and we thought that perhaps using virtual might be works at this point of time as an introduction. So we integrate IPE into virtual reality, which is perhaps the best potential solution. I'm sure all of you perhaps have gone through Roblox, one of the gaming environment, the 3D environment that can bring you anywhere in the part of the world. It is an innovative 3D environment for networking. So like my kids, when they play here, they meet all their cousins, all their best friends, come and visit their castle, for example. They develop castle, they develop their imaginative home. They become the boss in one of the company, so they develop their whole imagination. So I thought that perhaps if we're using the same model, we develop our own clinic in this world reality, perhaps it works for our students. So that's kind of the idea. So we identify several platforms, and as of that I know, Second Life is one of the platform, but it's more adult platform. You can find everything here, good and the bad one. So be careful when you're exploring here. So and the reason why I'm using Second Life, before we go, any one of you has been in Second Life before? Can Can I have an answer? But all right. Anyone? Okay, so maybe not familiar. So the Second Life is one of the VR platform, beside Roblox and so on. It's an innovative 3D environment for networking and interaction. It has been used to teach simulation-based environment. So I have seen a lot where they use Second Life to teach students about emergency medical case, a surgical case, smoking cessation, exercise, even delivery. Perbidanan. So mereka ada. And this is all the papers that they have come out with simulation, fire accident, medical education, obesity prevention, as well as family and community medicine education, where they use something like family planning, how to talk to the client about family planning, or sex education, which is sometimes can be so sensitive. So they start first with virtual education. So when I look into this, and I decided to use obesity because number one is limited study. Second, because we already have the model of interdisciplinary management in our clinic. So therefore, in this presentation, we look into the development of the VR, with the obesity clinic as a model, and we use Second Life as a platform to provide an engaging and immersive learning experience that reflect student real clinical scenarios. So we use obesity nutrition care process as a guidance and framework to develop the platform. It starts with assessment, diagnosis, intervention, monitoring, and evaluation. So this is our obesity care process in our clinic. So we use this as a framework to develop. So before the clinic, the nurse manager will call the patient, will arrange and scheduling all the visit. And during the clinic, the nurses will help the patient to go for assessment, and then bring them and guide them to necessary health profession that will seeing them during the clinic. And so they will review the case and do all clinical workup, and nurse conduct the set of assessment that given, and patient come to be seen by either a dietitian, surgeon, and other healthcare professional that was scheduled during the day. So after that, we have to discuss the case and plan. Sometimes when it comes to very difficult plan, all the team members need to be discussed together. What is the best treatment plan for the patient? So then we set the follow-up, and then we coordinate of care to other discipline as needed, and we monitor and follow up their progress. So this is the Second Life. So you can see here, this is my hospital. I can say that because we developed those. We buy, it's quite, you need to buy the land. You need to buy the land. So I bought the land near because this is immersive, it's a virtual. So I bought one land near to the laut, tepi laut. So it's very nice hospital lah kononnya. So this is our building of the hospital. It's it's a fourth building of the hospital. Where when the patient come, they can enter. So this is myself, where we tried. So they enter the hospital, they go to this building, and this is where they have a registration area. So here, when we wanted to play this, student will register themselves, and they use their own avatar. Either they are nursing student, medical student, and dietetic student. So one group is about 4 to 5 students with different discipline. So this is the registration area, which the nurse manager has an important role to guide the patient. So after that, the patient need to go for assessment, where when we click here, all the patient detail will be pop up or appear. So where the student can actually discuss on the details. And this is the overall picture. So this is my patient. We designed this avatar, came to our clinic. So but before that, student will sit in their learning area awaiting patient to come and to discuss the case before they go and see the case. Yeah. So when this patient comes in, they go for assessment, and after that they go for consultation. I forgot to snap a picture of consultation room. Yeah. So as part of the obesity management, we also create the cafe sehat, in cafeteria, because we wanted patient and the student to learn how to make a healthier food choice when they go to the cafeteria. Yeah. So when they have handled the patient, when they have discussed, and we will have a seminar room for the discussion and the debriefing of the case. Yeah. So as a summary, this project is still ongoing. We only have tested about a very small group because we have just finished the development process. Yeah, we hope that the usefulness, student able to apply, discipline-specific patient assessment and care, as well as plan and participate in IPE at virtual world. What are the added value? The use of simulated patient would have been extremely challenging and not easily reproducible. So with this simulated case, student can come anytime they want, and they can try many times, together with their other healthcare professional to try the system. So the system is already built, and it can be reused many times with a variety of student cohort, which highlight the cost effectiveness in teaching and learning. So what are the way forward? So I guess IPE can be used across the globe because it's only virtual reality. One of the study in United States has been using this technique to combine all students across the globe. And second, it can expand to other medical issues beyond obesity, such as diabetes, CVD, and cancer. Our hospital has been developed, but now we're focusing on obesity. But I believe there is a lot of other potential, sebab dia 4 tingkat dan banyak lagi bilik kosong that we have yet to explore. And besides student, we can also teach and train other healthcare professionals who are interested in IPE. With that, thank you very much, and kembali kepada Bapak pengerusi majlis.
Right, thank you very much, Mrs. Barakatun, for the interesting presentation. And now, I think I see the 4 points according to this topic. First one, interprofessional education, IPE. In case for managing obesity, IPE refer to a occasion when students from 2 or more professionals learn together to collaborate with one and another profession, such as doctor, nurses, dietitian, bariatric surgeon, and another profession in health worker to manage obesity in this case. The second one, virtual education in IPA. Because of this pandemic and one another, we cannot do workshop about IPA in face-to-face. So IPA is the solution for the student to mastery the learning outcome, I think. The third is the second life. It's one of the models, I think. This application is useful for students to be able to discipline specific patient assessment and care planning, as well as participate in IPA at a virtual world. And the last one, way forward, IPA cross the globe between UPM, University of Putra Malaysia, and other institutions worldwide, expand to other medical issues beyond obesity, such as diabetes, CVD, and cancer, and expand role beyond student, but can also be applied to working adult in healthcare areas. Okay, I think we still have 15 minutes for discussion session. I will give opportunity for the participant. Perhaps there are any question. Please address your question, whether directly or by live chat. Before asking your question, please state your name and your institution clearly. And Mr. Barakatan will answer your question broadly. Well, ladies and gentlemen, if there are any question, please. I'd like to have 2 or 3 questions for the first.
Yes. Am I audible? Yep.
Okay, please.
Good afternoon, Mr. Ismansyah. I wanna ask a question.
Say your name, please, and where you from, and ask your question.
My name is Maria Regolinda Olo. I am a student from Health Institution of Borneo.
Yeah.
And I want to ask a question about this virtual reality. We use this application. We can say this is an application to do IPA between the professions. My question is, in collaboration between nurses, doctor, and another profession, we need like communication skills. And how will we improve our communication skills in this IPA? I mean, this virtual reality have no, I can say that have no strategy for the personal, the human to talk in person with the communication, right? So what should we do, to improve our skills of communication, because we need the communication to speak with another profession and also to the patient, right? All we know that is, right? Then that's my question. What kind of, how should we manage the communication skills, and how should we improve it during or use these applications? Thank you.
Okay, welcome. Mrs. Barakatan, you got the question?
Okay, yes, I got the point. Thank you very much. Yeah, student, you have a very valid question, and you realize that the main component in IPE is professional communication. The best and the beauty of Second Life, where people who are being in Second Life, they can verbally communicate. Yeah? If they have a sound like Zoom here, yeah, they can communicate and they can express their interest and they can do a live consultation. Because during the Second Life, people need to, like in the Zoom, you have to log on and you have to choose your avatar, and then you have to put your name in, and then you can start communicating. So communication is not an issue. Yeah, I have the same feeling, but a study that I have shown you just now, yeah, that published early this year among the pharmacy students, they also have that kind of concern that students may not be able to improve in terms of their communication skill. Yeah, if you remember the slide that I have shown you. But at the end of the study, they found that students, in fact, they are very glad to be given a chance, yeah, to start doing the IPE, the initial one, before they are being introduced to the real case scenario. Yeah? So I guess, you as a student, when you go for the first time to the hospital, it's quite overwhelming. Am I right?
Right.
So, namun dalam konsep Second Life ataupun penggunaan virtual reality, we provide immersive learning similar to what gonna happen in the real life as a beginning. I'm not saying that this will change the overall landscape of teaching. Yeah, this is something like a potential to start with. Okay? Right. I hope, yeah.
Thank you very much for the answer. Okay, next question, please. Thank you, Maria, for the question. There's no question more?
No more questions, sir.
one more question.
Thank you for the answers.
All right, I think if there are no more questions, we shall end the discussion. Thank you very much, Mrs. Barakatan, for the sharing useful information. Hopefully, we can meet in another occasion.
Insyaallah. Terima kasih ya, Bapak.
Terima kasih, and thank you
Ya,
for the
Assalamualaikum.
audience. Waalaikumsalam warahmatullahi wabarakatuh. Thank you for the audience for attending and lively discussion. And give a lot applause, great applause for Mrs. Barakatun. Okay, thank you and see you next time. Now we going to the next session for the fourth session or the last session for today's seminar.
Indonesia sejak dulu kaya akan nilai-nilai yang luhur dan mulia. Kerjasama adalah salah satunya. Sebuah prinsip dalam bekerja demi meraih hasil yang bisa dinikmati bersama. Di dalamnya terkandung nilai-nilai kesetaraan, kejujuran, saling menghargai, dan percaya untuk maju bersama. Untuk itulah, kami hadir membawa nilai-nilai yang sama. Sinergikan 3 bank syariah besar dan bertransformasi menjadi bank syariah yang inovatif, modern, dan memiliki visi global, bekerja sama dengan seluruh umat demi meraih berkah bagi seluruh alam semesta. Karena kami percaya, inilah nilai-nilai Indonesia demi memajukan ekonomi umat. Bank Syariah Indonesia.
Okay, ladies and gentlemen, we're going to the fourth or the last session. Mrs. Era, are you there? Ready? Okay. Okay, please welcome Dr. Dwi Prihatin Era, Master in Medical Surgical Nursing from Medical Surgical Nursing Department, the Health Polytechnic of East Kalimantan, Ministry of Health of Republic Indonesia. I'm very pleased to introduce her. Okay, now Mrs. Era's profile. Okay, thank you for the video about Mrs. Era's profile. Mrs. Era's current position now is Senior Lecturer of Medical Surgical Nursing Department of Health Polytechnic of East Borneo. Mrs. Era further inform you that we have 45 minutes, 30 minutes for presentation and 15 minutes for discussion. Well, ladies and gentlemen, may I now invite Mrs. Era to give the presentation by topic, telenursing in empowering cancer survivors. Dr. Era's 30 minutes is yours.
Okay, am I audible?
Please.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you for all the committee for giving me the opportunity to be the speaker here today to bring my topics that is about telenursing in empowering cancer survivor. As a premise, telenursing is the interaction of a nurse with their colleague and a nurse with a patient that is facilitated by media and equipment that eliminate distance and time barriers. As we frequently read or hear that telehealth care is interchangeably used telenursing and telehealth care is interchangeably used to indicate that this is the care that is given by healthcare to other patients using media. This activity enables human interaction to continue to be entwined despite numerous limitations. We know that a lot of limitations may exist in the delivering nursing care, and we will talk about that. And the telephones, whether it is landlines or cellular, also the internet, video and video conferencing and devices for general data transfer are the most often utilized media. Okay, and telenursing use this kind of technology to provide nursing practice at a distance, which may help solve increase of nurses, reduce distances, and save travel time and keep patients out of hospital. Because in Indonesia, the shortage of health worker is can be seen in the many of the areas. For underserved communities where there is shortage or absence of adequate clinical care, we can use this kind of activity of taking care of patients. Indonesia itself has 62 remote counties known as 3Ts. In Indonesia, we say terdepan, tertinggal, and terluar, or outermost and underdeveloped areas. So this is one of the reasons why telenursing is the activity that suit for to be applied in Indonesia. And also another reason is rather than move the patient to the clinical setting, and sometimes this is hard for us to bring the aging patient or the chronically ill and other patients who have very limited abilities to hospital. This is it is now commonplace to harness the power of technology to transmit the knowledge of the health workers. So we don't have to bring the patient who is cannot afford it, and we bring the knowledge to the patient's house. Some of the evidence base is a key objective telehealthcare or telenursing is a key objective of the digital agenda for Europe and a key feature of the UK's NHS information strategy. It means that in Europe itself, telehealthcare can be used to run or to apply the nursing care or health care so that everyone can get the standard of care that he or she needs. And then another research saying that the promise of telehealth care to improve the convenience, the quality, the safety, and cost effectiveness of care has big international interest. As some results shown us that in another part of the world, telehealth care is used, whether it is in Africa or in Europe or in America and many other continents and countries. This has coincided with the realization that existing healthcare delivery methods may not be able to handle future levels of chronic disease in aging populations. As we know that some of the advantages of the education that is given to patients and their family is that they have enough knowledge about how to take care or to keep they stay healthy. Moreover, in the population of aging or in gerontology, this bring up that the number of population is increasing. So the increasing number of aging patients will bring also disadvantages that they cannot go or they cannot move to the health facility as much as the younger. Many studies showed no differences in outcomes between telehealth care and usual care, and of course, these points have to be read carefully and transferred into the activity that is fair. This is the portrait of Indonesia, which have the characteristic of geographic and development. I think this is as the same portraying many other developed countries, which we have the limitation in the geographical and also the development of areas in Indonesia. So not all Indonesians have the opportunity to enjoy the standard of health because of the remote areas they have, also maybe the low standards of economy that hinder them from getting the best standard of health care. And telehealth care delivery the activity of caring at a distance. While in distance, we still have to support patients in how they manage their self, because telenursing or telehealth care means that we still have to observe, we have to monitor, and we have to give them the personalized feedback. And we hope that with telenursing or telehealth care, there will be no geographical limitations, no transferring aging and chronically ill, and no excess costs. And of course, this will exist after we do some setting up. For the first, we need to set up the fund, because funding for some developed countries is scarce and maybe it's not feasible. So we have to set up the fund to help us in to help us in prepare suitable technology, because as we mentioned before, that technology is part and the biggest aspect of telehealth or telenursing. For some countries which is developed, such as in Indonesia, maybe this is not really much money can be used to buy or to set up the technology. And then a government assistance as a support to this activity is very important, because we need the integration of the care that is given through the legislation and regulation. This is all for the protection of the patients and for the health worker themselves. And then the third is enhancing literacy. We need to support the literacy in the healthcare workers and also in the patient themselves, because without having a proper knowledge about how to use computer or how to use media, and then the telehealth care is not possible. And then what about the application of this telenursing in oncology nursing? Oncology nursing is the part of nursing who is focused on the care of patients with cancer. In cancer survivor, as many up to 65% of survivors indicate that when they feel tired, they were advised to increase the amount of or quality of rest and do other sedentary activities. It means that they were told to increase the amount of sleep and rest and sleep and rest. And many women deliberately reduce their physical activity after diagnosis of cancer. Though this is not true, because according to many research, cancer-related fatigue cannot be alleviated by prolonged rest or sedentary habits. Since multiple studies have shown that carefully assessed and designed physical activity has numerous advantages with few side effects and adverse occurrences. So how will nurse teach or build or make a program to make sure that cancer survivor alleviate the fatigue, cancer-related fatigue? Physical activity also has been advocated as a non-pharmacological intervention that can help people feel better during and after cancer treatment. But unfortunately, lots of health worker and maybe also patients and their family doesn't have the enough information about this. So some of nurses in Indonesia are interested in studying fatigue in order to get more information, to develop interventions, and to test models and strategies. All for the target is to make a cancer survivor having a best quality of life. As we said before, that in Indonesia, patients have limited resources. The cancer survivor, they have limited resources, whether it is time or money. As we know that money or fund or money is important for them to follow the program that arranged for them. So this can cause the non-compliance or non-adherence for them to the regimen of therapeutic. we talking about the program of activity that is arranged by nurses or by the clinic or by the doctor to make cancer survivor following the schedule of exercises. But, but the program but the program that we arranged for them is not suitable for them because those programs need them to come to the clinic every twice a week, while they have no enough money or they have no enough resources to come to the clinic every 3 days in a week. So it brings them to non-compliance to the program, and it means that there is low participation of cancer survivor. So this is the challenge that we have in Indonesia, how to develop empowerment-based program for cancer survivor who experience fatigue, because fatigue is the leading cause of low quality of life, because of cancer-related fatigue can cause many other detrimental effects to cancer survivor. As a profession, nursing care that is applied by professional nurse, it can come to as much as role that we can apply to our patient. First, we can be a care provider, we can be advocate, we can be educator, and we can be a communicator to our patient. And we use these roles to help provide emotional support, to give medical assistance, to give a clinical intervention and health education, also to conduct teleconsultations, review the findings of medical tests and examination. All are the intervention that we use to give patient to include them in the program of cancer survivor, and as a target that we want them to be increased in their self-efficacy. And using telenursing or telehealth, we empower them from distance. By this way, we put a solid base for them to perform physical exercise alone at their home basis. This can be done after we do several applications to them directly, and then we observe them, we help them at their home. So by empowering survivor, they actively involve in the process, and they exhibit self-management. By increasing their self-efficacy, nurses can see that this will bring patient to manage their self in their health status. So empowerment is a method of enhancing self-efficacy to increase compliance and become a focal point of the nurse's attention. Empowering cancer survivor is by teach them about cancer-related fatigue directly, and then we teach them about physical exercise and writing. This all to channeling psychological fatigue, because after teach them directly, then they can repeat the physical exercise, and they can do the writing exercise or anything that we arrange to be their program. And then we have to contact them on regular basis, maybe every 3 days or every week, to ascertain whether the program was carried out consistently. This is the part of our role, that is to make sure that the program that we arrange is being conducted consistently. or whether they encountered barriers or difficulties in carrying out the program. And we also have to remember that empowering patient or a cancer survivor means that we have to empowering their family too, because every family member, because family is the system, whether it is their spouse, their parents maybe, or their children, or non-blood relatives. And this is part of educator role for nurse. We have to do all of this work and the standard and that we need to obey. First is continue to work based on the scope of nursing, including nursing ethics. We must not forget that every work that we do as a healthcare worker is limited by the ethics, work ethics. Some of the nursing ethics that we have to remember is no maleficence, beneficence, veracity, justice, and you can say it more, about ethics. And we have to work using verified work standards. In clinic area, of course, hospital or nurse, we have standardized standard operational procedure that must be obeyed, so that this will protect patients and also protect us as the healthcare workers. And also have to have a valid work permit which prepared issued by Healthcare Council of Indonesia. And in applying telenursing or telehealthcare, we also have to remember that we need tools. This is some of the tools that I use in empowering my cancer survivor. That is booklet, and then video, and then workbook for nurses that they have a standardized step-by-step work how to apply the telenursing or telehealthcare to our patient. And all of these tools need to be valid and reliable. So maybe you have to consult to other professions such as doctor, or maybe a therapist, or maybe a dietitian, and etc. Okay, as a summary, Indonesia needs remote service methods according to several characteristics, and these are lack of professional health workers, because according to WHO, Indonesia has the shortage number of nurses, the most serious in the world. And also, as we see that the geographical location of Indonesia with remote and underdeveloped areas, also unfavorable economic conditions as a result of that we are developing countries. And then the use of the services of telenursing must be supported by several arrangements to ensure that both health workers and patients are protected and supported by regulations. And we need to use applicable standards and using valid and reliable tools. Suggestions is the hope is that Indonesia has special telehealthcare program such that in Brazil and many other countries in America to meet the need for integrated health services, so that a high quality of life for Indonesian people can be achieved. And telehealthcare does not have to change how we provide services, because services should not be constrained by distance or time, but telehealthcare provides alternative methods in all the challenges we face today, both in terms of distance, cost, and time. I think that's all from me.
Okay.
Thank you.
Thank you very much. Ladies and gentlemen, give great applause for the speaker. And Thank you, Dr. Dwi Praten Era, for giving such information and interesting presentation, I think. This is my conclusion for this topic. What the mark of the end of the presentation of our last source person for today, Dr. Dwi Praten Era, Master in Medical Surgical Nursing, with the title of presentation, Talent Nursing in Empowering Cancer Survivor. First, telenursing is the interaction of the nurse with the another nurses and nurse with the patient that is facilitated by media or equipment that eliminate distance and time barriers. That deliver that activity of caring at a distance and still support patient management through remote monitoring to no geographical limitation, no transferring agent, and lower cost, of course. Many cancer survivors suffer from cancer-related fatigue. The cancer-related fatigue is a feeling of tiredness and cannot be alleviated by prolonged stress that is related to cancer. For the research shown that non-pharmacological intervention is more effective to help cancer survivor or to relieve the side effect from the treatment or the cancer itself. The third is with the telenursing, we can provide emotional support, practical assistance, clinical intervention, and health education to patients, conduct teleconsultation, etc., with the final goal of increasing patient self-efficacy and, of course, we hope their health will increase by the intervention, and to empower them to put a solid base for them to perform physical exercises alone at their home basis with 3 methods. First, which by increasing their self-independence, by giving the information about the matter. The second, by giving guidance with maintaining good communication. And the third, to also providing knowledge and skill to the related family. Okay. We have enough time, I think, 15 minutes to open the session, this discussion session, and I hope the participant will give a question. I'd like to have 3 questions from the participant, please. Okay, please address your question whether directly or by live chat. Before asking your question, please state your name and your institution clearly. Okay, any question?
This. Thank you, Dr. Era, for amazing presentation, and introduce me. I am Fadil Hanidia from Health Polytechnic. Health Polytechnic is Borneo.
Okay, your question.
Okay. So my question is, if this program running effectively, what is indicators of success of this program? And what is the main obstacle in application of telenursing in specifically in Indonesia, and how to overcome it?
Okay, Mrs. Sarah, you get the point?
Okay, I got the point.
Okay, please answer the question.
Okay, thank you. Ms. Fadila, your questions are the indicator of the success of the program, and then what is the obstacle that we face in applying this kind of activity. First, the indicator of the program success is that we have to evaluate the intervention using in nursing known as a nursing process. So nursing process will let us know that whether or not our intervention is success or do we need to rearrange our intervention if the points of our intervention give us the unwanted results. So telenursing itself has not become the program in our country. So this is the activity that can be used. So as Ms. Barakatun has said before, that this is this kind of activity is enhanced by the condition that we face today, that is of the pandemic. So we can use this kind of activity and use it to be the solution of the problem of our patient. So anyone in healthcare area can use this kind of activity in solving the problems of patients. But to make this the formal program of our country, this is to answer the second question. We have so many obstacles that I said before, that I mentioned before in my slide. That is one. We don't have much fund to make this activity as a program, because we still have a lot to be set up, to be arranged. First of all, maybe the obligation the obligation in the form of legislation or a regulation, but we can still have we can still apply this kind of activity caring using the standardized of our profession. And then the another obstacle is maybe in ourselves, that we don't know how to apply this kind of activity in our caring. In nursing, we can do our telenursing by first of all, by make sure that we have enough tools and standardize step by step to make sure that we go to our patient or we contact them virtually, but still we have standardized acts of a professional. I think that's my question. I hope it answers.
Okay, thank you for the answer. It's clear for you?
So clear. Thank you, Miss Era. Thank you for the answer.
Okay, thank you. Okay, any question? Any more question? We still have enough time, maybe around 5 to 10 minutes. No more question? Yeah, if no more question, we shall end the discussion now. And I wish to thank you to Mrs. Dwi Prihatin Era for the interesting presentation, and to the audience for attending and lively discussion. Thank you very much. See you next time, and give applause to the great speaker today, Mrs. Era. Thank you very much, and I'll back it to the Master of Ceremony.
Okay, thank you for Mr. Isman Shah, Master of Nursing, for moderating this session. And we finally come to the end, and we hope you found all of the presentation and all of the discussion at the seminar are informative and helpful for us.
Last but not least, in this opportunity, I would like to extending our appreciation and thank you to the representative from
Ministry of Health of Republic Indonesia,
Director of Health Polytechnic of East Kalimantan, along with all staff,
our great speakers and moderators,
our sponsorship from Bank Syariah Indonesia,
and to all participants and committee parties in this conference.
As the Master of Ceremony, on behalf of the organizing committee, from our deepest heart, we apologize in case there were some of our mistakes and flaws in guiding this conference. Billahi taufiq wal hidayah.
Wassalamualaikum warahmatullahi wabarakatuh.
Okay, see you next conference.
For information to all the participants who join oral presentation, the section will be start after the break, and you can enjoy the poster presentation that has been submitted to this event. And after that, the participant of oral presentation can join one of the breakout room in Zoom meeting. Thank you.
This period has given us plenty of moments to pause, to reflect on the moments we used to call normal time, and to take the right actions in the era of new normal. Nature and culture has many stories to offer. In the era of new normal, many things have changed, including exploring East Kalimantan. Keeping your hands clean, feeling the freshness of natural water, diving down into the perfect blue depths of the beautiful sea, self-isolating in a signature hidden forest of East Kalimantan, wearing a mask when enjoying the exotic culture, maintaining your distance from the crowd has never been this relaxing. Exploring in every direction, crossing the heart of Kalimantan with your security a priority, offering an experience to connect with nature, staying in an eco-friendly lodge, breathing in fresh air, creating eco-friendly art. Everything can be found right here. Art and culture, nature and wildlife, adventure and sport, water activities, events and festivals, food and drink, shopping and souvenirs. It is true that everything has changed. Visiting East Kalimantan will always give you excitement and limitless experiences. See you in East Kalimantan. Escape to East Borneo. Lost in paradise.